in your lecture and extra stuff. And I've tried to explain it to the best of my ability. So yeah, we can get started now. Also, I need all of you to be interactive during the session. So it's only going to work if you're interactive. So when I ask something, please answer. Either unmute yourself or in the chat box. And yeah, that's it. Let's get started. So we'll be covering these 4 lectures today. And I've demarcated when each lecture starts and ends. So you'll know exactly what's included in each lecture. So we're going to do the first lecture now. And again, please text or stop me if you have any problems, and I'll answer them. Right. So there's 2 types of anatomy. There's gross anatomy and histology. Gross anatomy is everything that you see macroscopically with your eyes. So like if you see a bone, if you see a muscle, that's gross anatomy. If you see connective tissue, that's not gross anatomy because you wouldn't know it's connective tissue. So that's histology. So when you need to look under a microscope to identify something, that's histology. So like if you see skeletal muscle, cardiac muscle, smooth muscle, you see epithelium, all of this is histology. All right. So now we'll talk about the anatomical position. What is the anatomical position? Well, you don't need to know the definition. All you need to know is how it looks. And this is extremely important for you to remember forever. Everything that you talk about in anatomy is going to be in relation to the anatomical position. So basically, as you can see in the center, the anatomical position is when a person has their palms facing outwards with the palms slightly further away from the center of their body and their legs close together. So basically, like in this diagram, which you see is an anatomical position. And if you can't remember it, it's basically what Ronaldo does when he does the Sus celebration, except the legs are close together and not far away, like Ronaldo's. So that's an easy way for you to remember if you forget. But everything that you learn in anatomy is going to be in relation to this. So it's extremely important for you to know the anatomical position. Basically, like sear this into your mind, how it looks. Because everything that we describe will be according to this. It's like the basic standard for description of anatomy. As you can see, the over here, the palms are facing out. So like this, right? I don't know if you can see on the screen, but this way. And then the legs are close together, right? And yeah, that's it. Okay. Okay. Now we move on to the next, which is the orientational and directional terms. So basically, when we talk about anatomy, we need to describe what we're talking about. And how do we describe it? We describe it using certain terms. These are not the same as normal English terms. And the reason is because the body is so complex, those normal terms no longer suffice. You know what I mean? So like you can't use words like above or below or behind, and you can't use these terms. You need to use specific terms. And I'll tell you how to use them. And we'll have examples and we'll have pictures to make you understand, right? So the first term is superior. Now, when you usually speak normal English with your friends, you would say something like above or on top of. So that's the same thing. That's pretty much what superior is. It's like something that's on top, towards the top of our body. So like my head is superior to the pelvis because the pelvis is, in the middle, and then your head's all the way at the top. So your head is superior. Your shoulders are superior to your ankles. Your ankles are all the way at the bottom, and your shoulders are at the top. And your heart is superior. Sorry, your heart is superior to your stomach because it's above it. So superior is also called cranial, and this is important because sometimes they're used interchangeably. And cranial is derived from the word cranium. Our cranium is basically the scientific word for the skull, and the skull's on the top of our body. That's why cranial is another word for superior, but they mean the same thing. Cranial and superior are the same thing. Now we're going to move to the opposite. That's why they're on the same slide. Inferior. So inferior is also known as caudal. So some people say superior and inferior, others say cranial and caudal, but they mean the same thing. So why is caudal called inferior? Caudal translates into tail, and us humans don't have tails, but during evolution, according to evolution, we evolved from monkeys, right? And monkeys have tails, and their tails are at the bottom of their body. That's why inferior is also referred to as caudal. So what are some examples that we can use? We can say our hands are inferior to our neck. So my neck is all the way up here and my hands are down here. So my hands are inferior. My biceps are inferior to the ears. The ears are all the way here, and then the biceps, they're down, they're below. So inferior and below are basically the same thing. And then the bladder is inferior to the kidney. Your kidneys are your trunk, and then your bladders are at the bottom. Your bladder is at the bottom, right? So I hope you guys understood this. There's a lot more coming, but did you guys understand this? Can someone unmute? Okay. Can someone unmute or like chat, put it in the chat. Did you understand this concept so far?
That's clear, yeah.
Yes.
Okay, great. Now we move on to the next one, which is ventral and dorsal. So ventral is also called anterior. You may have heard anterior before, anterior and posterior, basically in front of and behind. But instead of using those words, we use ventral and dorsal, or anterior and posterior. They're both the same, and they're opposites of each other, just like superior and inferior are. So ventral means something that's at the front of our body, and dorsal is something that's at the back of our body. And again, this is in relation to the anatomical position. In the anatomical position, this part of your body is the front, and then your back is the back, right? So our nose is ventral, our lips, our knees are ventral, our heart is ventral, our trachea is ventral. So basically, it's not only things that are at the surface of your body. So not only things that you can see. Your heart, you can't see it, but according to anatomy, it's ventral. It's just under the surface, right? Below the rib cage. It's ventral. Our trachea is ventral too. Now dorsal, our glutes, they're dorsal. Our hamstrings are dorsal. They're in the back according to the anatomical position, right? Our calves, they're dorsal. Our kidneys are dorsal. And our spinal cord is dorsal. Now, the kidneys and the spinal cord, you can't see them, but they're at the back because of anatomy. Our kidneys, they're in the back. They're in the back of our trunk, And then our spinal cord is in the back as well. You can't see them, but they're dorsal. They're in the back of the body. And then we have medial and lateral. So medial is anything that's towards the midline of our body. So imagine there's a person in an anatomical position, right? And you draw a line that divides them perfectly into two. So it goes through their nose, through their lips, and divides them completely into two. That's the midline. It's an imaginary line, right? So now, if there's anything that's close to this line, that thing is medial. And if there's anything that's not close, that's lateral, right? So you can say our heart is medial because it's right near the midline, like slightly towards the left, but still it's close. Our trachea is medial, perfectly in the middle. Our esophagus is medial, perfectly in the middle. And then we have lateral, so something that's away from our body. And again, remember, this is in relation to the anatomical position. So when you're in the anatomical position, your hands are like this, right? So your thumbs are lateral. They're the farthest finger. The pinky is the most medial one, which is the one that's closest to the midline. And then your thumbs are lateral. They're the farthest away. Our pinky toe, for example, on your foot is the farthest toe from midline. And I'll show you a picture that will make it more clear as soon as we're done with all the terms. Now we have proximal and distal. So basically, when you have a thing called a skeleton, right? And there's two types of skeleton. There's two divisions in the skeleton. One's an axial and then there's appendicular. But let's forget that. So basically, you have a joint, any joint in the body, your shoulder joint, your elbow joint, your wrists, your knees, your hips, any joint. So if you have a part of the body that's close to an origin point or a joint, basically, that's called proximal. And you have anything that's further away from the origin point or a joint, that's distal. And again, proximal and distal are used in relation. Like you can't just say, oh, this is proximal. You have to say, this is proximal in relation to this. So for example, you can't say your shoulders are proximal. You have to say your shoulders are proximal to your elbows because this is the shoulder joint, right? So the shoulders are the thing that are closest to the shoulder joint. That's obvious. So your shoulders are proximal. Your elbows are all the way down here. They're further away from the shoulder joint. So you can say your shoulders are more proximal than your elbows. Now, you can also say, for example, your elbows are distal to your shoulders. That's the same thing as saying your shoulders are proximal to the elbow, right? You can say your hips are proximal to the knees because your knees are further down from the hip joint and your hip is at the hip joint. Or you can say our wrists which is this, are proximal to the, this should be metacarpals instead of carpals. So I'm just going to correct it. Okay, I'm sorry for my handwriting. It's not great. Okay, so your metacarpals are basically wrists, are bones that you have after the wrist. Wait, 1 second. I'm seeing something in the chat. Right. So basically, the metacarpals are bones that you have in your hand, and this is your wrist, right? And then these are your metacarpals. So your wrists are proximal because they're the closest thing to the wrist joint, and and the metacarpals, which are these, are further. They're after the wrist, so they're distal. And then the other examples we have are our elbows are distal to the shoulder because we're comparing now to the shoulder joint. So the shoulder joint, the shoulder is much closer than the elbow. Or our ankles are distal to the knees. So the knees are a joint, right? And our ankles are further away from the knees than the knees themselves. So they're distal to the knee. I hope that's clear. If that's not clear, please let me know so I can try and explain again. Is that clear? Guys, is that clear? Can someone? Okay, good. Okay. And now we have, I think this is the last one before we move to pictures, right? So we have superficial and deep, and this is really easy. If you have anything that's at the surface of your body, that's superficial. If you have anything that's within your body, that's deep. So your skin is at the surface, it's superficial. Your nails, they're superficial. Your hair, it's superficial, right? And then deep, it's anything that's within your body. So internal, right? Our heart is deep. You can't see your heart. It's within the skin, within the fat, within the muscles, within the rib cage. It's deep. Our brain is deep. You have a skull covering your brain. You have hair, you have skin, all of that covering it. So it's deep. Our pancreas is deep. It's somewhere deep within the GI, within the stomach, you know? So that's it for all the directional terms. So basically this was what do you call it? A dictionary on how to understand anatomy. And now we'll move to pictures that hopefully make it a much more clear. Okay, so here you can see this blue line is the midline of the body, right? The one that you drew. And now anything that's close to this blue line is medial, and anything that's away from it is lateral. And you can see, right, that here your thumbs, they're far from the line. Like there's this much distance from the thumb to the midline, so they're lateral, right? Whereas your heart would be somewhere over here, right? That's not how the heart looks, guys. That's just a picture, a drawing, right? So this is close to the midline. So it's medial, right? Similarly, your trachea, which is somewhere over here in this area, is medial because it's right at the midline. And then in relation to that, like your shoulders, they're lateral, right? Because they're farther away. So now if you want to use it to compare, you can say, for example, your umbilicus or your belly button is more medial than your elbow. I don't know. Your elbow is over here. Okay. So you can see the umbilicus or the belly button is much more towards the midline than your elbow. Your elbow is farther away. So your elbow is lateral compared to the umbilicus, or the umbilicus is medial compared to the elbow, right? Then we have this. This diagram has basically everything. So superior means anything that's towards your cranium. Okay. So cranial, superior. Inferior is anything that's caudal. So anything that's down is inferior or caudal. Anything that's up is superior or cranial. Then you have lateral and medial. Anyway, this is the midline over here. So anything that's close to this is medial. Anything that's away from this is lateral, right? And then you have proximal and distal. So this is the thing that most people get confused about. So basically, what you're gonna do is take a joint. Okay. So the knee is a joint. This is the knee, right? So the knee is, if you want to compare the knee and the ankle, and you're taking the knee joint as a reference, you're gonna say the knee is proximal compared to the ankle. Because look, this is the joint that you're taking as reference. So the knee is right here. The ankle is all the way over here. It's farther away, right? So that's why it's distal. Now, if you were to take the ankle joint as reference, right? Again, that doesn't change anything. The ankle joint, you take it as reference, okay? So, but the thing is here, you have to go like the joint that's closest to the axial skeleton. So your skeleton in the back, your hip is the first joint in the lower body. So anything that's below the hip is going to be distal. right? And the hip itself is the most proximal. So even though the knee is proximal to the ankles, the knee is distal to the hips because the hips are the first joint of the lower limb. So anything that's below this is going to be distal, and nothing can be more proximal than the hips in the lower joint. But if you go like okay, never mind, let's not go into that. But like nothing can be more proximal because it's the first joint. Similarly, in the upper limb, your shoulders are your first joint, right? So if you want to compare your elbow to your shoulder, you're going to say the shoulder is proximal to the elbow because it's above the elbow, right? But then if you want to compare your wrist to your elbow, you're going to say the elbow is proximal because the elbow is it's like it's closer to where the origin is. The origin is the joint. You're comparing the joint. Do you understand this? I know it's confusing. I hope I'm explaining it well, but if I hope you understand. Do you understand this? Do you understand proximal and distal? Okay, great. Oh, that's really good. Okay, and then superficial and deep is the easy part. This is really easy. Anything that's on the surface, superficial. So you see, like this person, uh, his skin over the abdomen is superficial. But like, for example, anything that's within his body that you can't see with your eyes is deep. So like, for example, his stomach, his esophagus, all of these things are deep. So this is really easy. I know this is easy. Let me just erase everything so we can move on to the next slide. All right. So let's move on now. Right. So now we're done with the basics, right? We're gonna move to body cavities. So basically, your body is divided into two main cavities. There's a dorsal cavity, and what does dorsal mean? Someone tell me in the chat. What is dorsal? Right. Posterior, back. Both of those are correct. Exactly. So in layman's terms, you would say back, which is okay because I asked you for a definition, but in an exam, you would never say back. Dorsal or posterior, both of those are correct. So this cavity is in the back of your body. And then you have a ventral body cavity or an anterior body cavity. This is present in the front of your body, right? We have this really nice image here. So basically, in this, you can see what's coded as blue is your ventral body cavity, and then what's coded as orange is your dorsal body cavity. So your dorsal body cavity is divided into two further cavities. The first one is the cranial cavity, which is pretty it explains itself what it is. It's the cavity within which the brain is. So that's the cranial cavity. And then you have a spinal cavity or a vertebral cavity. And this is the one within which the spinal cord resides, like which the spinal cord is within this. So this part right here is your cranial cavity, which is a part of your dorsal body cavity, because you can see it's towards the back. And then the rest of this, all of this is your vertebral cavity. And again, you can see it's in the back, so it makes sense that it will be dorsal. Then you have a ventral body cavity, and this is located in the front of your body, right? And this is divided into two, and these are a little bit longer and more complex than the dorsal ones. So you have a thoracic cavity, and you have an abdominal pelvic cavity. So the thoracic cavity is this one right here. Let me draw it for you. This thing is the thoracic cavity. Now the thoracic cavity has two further divisions. It has a pleural cavity and a pericardial cavity. The pleural cavities are these right here. One, okay, and two. These are the pleural cavities, and as it says in the name, pleural means lungs. So the right pleural cavity is the one in which the right lung is. And then the left pleural cavity is the one within which the left lung is. And then you see three. This is your pericardial cavity. This is within which you have the heart. So the heart is within the pericardial cavity, and the two lungs are within the pleural cavity. And both these cavities are part of the thoracic cavity. And then the thoracic cavity is part of the ventral body cavity. Clear? Is that clear? Can I get a yes? Okay. Okay, great. Okay, good. Wouldn't the heart be on the left? Yeah, look, the thing is the heart is tilted towards the left, but it's still in the center. The heart is in the center and then it tilts towards the left. But for the sake of illustration on the diagram, it's shown in the center. Although you're right, it would be slightly on the left. but it actually is midline. It's central, and then it tilts towards the left. I hope that clears your question, Abdullah. Okay, so then you have the abdominal pelvic cavity, which is the second part of the ventral body cavity. Now, this is subdivided into abdominal cavity and pelvic cavity. So the abdominal cavity has the stomach, it has the pancreas, it has the liver, okay, and other small organs, maybe the spleen, some of it, but mainly the stomach, the liver, and the pancreas, right? These are in the abdominal cavity. So the abdominal cavity is this. Is 1 second. Is this part right here, abdominal, right? Abdominal, right? And then you have the pelvic cavity, which is somewhere over here. Now, this contains the urinary bladder, maybe part of the ureters, the urethra. These are all part of the, the urinary system. So that's in the pelvic cavity. And then also for women, they have the uterus in the pelvic cavity as well. And you may have parts of the large intestine. Okay, that's not important. This is important that we have this cavity, and the main thing in this cavity is the urinary bladder. So again, let me go over it one more time. You have the cranial cavity. This has the brain, and this is part of the dorsal body cavity. You have the vertebral cavity. This has the spinal cord, and this is part of the dorsal. You have the thoracic cavity, which further subdivided into the pleural and the pericardial, and these are part of the ventral. And then you have the abdominal pelvic, which is further subdivided into abdominal and pelvic, and these are also part of ventral. So that's it for the body cavities, and I hope you understood. It's really easy, actually, but yeah. Okay, cool. Let's move to the next slide. Yes, we have to erase this before we move on. Okay, perfect. Now, this is something I always struggled with, so I'm going to try and make sure you understand. When you're looking at the body, it's not enough to look at it from the surface. You need to know what's going on within, right? But how? You don't just cut randomly and be like, oh, I'm gonna cut my arm off and then look what's in my arm. No. You have a certain way of dividing the body into sections so that you can see the interior, right? So we're gonna start with the sagittal section. So sagittal section, okay, is imagine someone takes a knife, right? And then cuts down this way, all the way. As you can see in this picture right here, wait. Oops, sorry. In this picture over here, someone took a knife and basically cut them this way. So now they're divided into a right and a left. And once you open it up, you can see everything inside, right? So this way. Now you can see the right of the body and the left. They're separated. And now sagittal and mid-sagittal are the same thing. A mid-sagittal plane or a mid-sagittal section is when the right and the left are equal. So you cut it perfectly. So 50% of your body is towards the right and 50% is towards the left. Sagittal is not perfect. It could be 60% left, 40% right, or 30% left, 70% right, But mid-sagittal means 50-50. You cut it perfectly. And then you have a coronal plane. So sagittal, I asked you to imagine that someone took a knife and cut it this way, right? In coronal or a frontal plane, someone took a knife and they cut this way. So instead of there being a right and a left, there is a back and a front. You understand? There's an anterior and a posterior because of the way they cut. They cut this way, okay? Like this is a water bottle. If I were to cut it this way, right, there would be a front and a back. If I were to cut it this way, there'd be a right and a left. So right and a left is sagittal section. Front and back is coronal or frontal plane, right? And then you have the transverse plane, which is the easiest. It's just someone measured you. You're like 170 centimeters, let's say, okay? Someone measured 85 centimeters and then they cut you in half. Like your upper body is separated and your lower, like if I were to cut the bottle this way, if I cut it over here, there's the upper of the bottle and then a lower. So that's a transverse plane. So did you guys understand this? We have more pictures, but did you understand this so far? Can I get someone else? Okay, good. Okay, good. Thank you. Now we'll move on to the next, and there's pictures, and hopefully that makes it even more clear if some of you haven't understood it yet. So these are CT scans of the body. Now, this is one of the practical applications of there being planes. You can't, when you have a CT scan, you're gonna see certain areas. The computer is gonna give you in certain planes. So the first one Wait, I'm gonna test you guys on this, right? This is number one. Can someone tell me what plane is number one in? Frontal coronal, exactly. And how do I know? It's because it looks like someone cut this person into a front and a back. This isn't a right or a left, it's a front or a back. Here you can see the back. You can see, the person's liver. You can see their spinal cord. That's their back. You can see their back. So it's frontal. That's amazing. Okay, number two, the next one. What is that plane? Transverse. Amazing. You can clearly tell someone took a knife and cut this person at the point of their lungs. These things that you see, the black things, are lungs. And what you see in the middle is the mediastinum, right? This is a normal CT scan. So this is transverse. Amazing. And then the last one, can someone tell me what section it's cut in? Sagittal, exactly. You guys, this was easy because I was going to put all three and two are done. Okay. Sagittal. Here, you can clearly see this is not front or back. This is right or left. You can see from the side, you can see the entire spinal cord of this person has been split into half. So this is mid-sagittal section, right? Great. So I think you guys understood it, and I'm glad you did. So we'll move on to the next thing now. Now, there are certain areas that you need to know. You need to, know them by their anatomic names. Layman's language is no longer going to be suffice. So when someone says abdominal, they mean the region between the thorax. Your thorax is this region, and then your pelvis. So anything between that is abdominal. Antebrachial means your forearm. So your forearm is antebrachial in anatomical language. Antecubital means this thing. It's also called the cubital fossa. Okay, it's here. Your elbow is posterior, and then your antecubital is anterior. You guys remember from the terms. Axillary is your armpit. Brachial means your upper arm. So you have like a brachial artery. So if you know what brachial means, you know this artery is your artery for your upper arm. Celiac means abdomen, basically. So anything that's related to your stomach or your intestine, that's celiac. And so there's a disease called celiac disease. And if you know what celiac means, you know this is something to do with your intestines or your abdomen in general, right? Cephalic means head, right? This is really important. You need to remember this. It can be even used in like as a namesake for cranial or superior. So superior, cranial, cephalic, all of these mean up, superior, all right? Up, above, anything that you want to use. Cervical means your neck. So cervical is your neck. Sorry, not this. This is your throat. Your neck is back here. So basically you have cervical vertebrae, C1, C2. So costal means your ribs. So there's a lot of joints that have costal in them because your ribs connect to a lot of bones. So that's how you should know costal means ribs. Cubital means your elbow, right? Femoral means your thigh. So there's an artery called the femoral artery. So if you were to know what femoral means, you'd know this is an artery somewhere near your thigh, right? Gluteal means your buttocks, and lumbar means your lower back. So your lower back is lumbar. And you have vertebrae here as well, lumbar vertebrae. Um, do we need that for the exam? Yes, yes. You're going to be asked this for the exam, unfortunately. In fact, you'll be asked more, which is why I have this. So I'm not saying you need to know all of this, inshallah, but this you will remember this by the time you've been in medicine for a bit, you're going to remember this. So I'm not going to go over all of it. Maybe I'll go over some important stuff. Like, for example, thoracic means your chest. Well, let me get my pen out. Ideally, you should know all of this, but not now. Over time, you're going to know it anyways. Thoracic means your chest. Mammary means your breast. Umbilical, which I used it earlier, umbilicus means your navel or your belly button. Inguinal is really, really important. Inguinal means your groin. So this line over here this is your inguinal region, okay? And this is important because we have lymph nodes here, we have a ligament here, and we have a lot of other things that make it really important. Femoral means your thigh. So this area is your femoral area. This is not that important. Patellar, the patella, it's a bone present near the knee. And then you should also know pelvic region. This is your pelvic region. So, in the abdominal pelvic cavity, when I say pelvic cavity, anything that's on deep to this is on the surface, right? This is the surface of the skin. Anything that's deep to this is your pelvic region. I went over antebrachial is your forearm, antecubital is your cubital fossa, which is anterior to your elbow. And then cervical is your neck. Oral means mouth. Everyone knows this. Nasal means nose. Okay, that's pretty easy. Now we're going to go to the back. The cephalic means your head. Again, this is really important. Uh, okay, occipital. Okay, so this part of your skull right here is called is called the occiput or the occipital area. It's the one over here. Okay, occipital. Vertebral is anything that's in the midline in your back, where the vertebral column would be. So this is your vertebral area. Brachial is your arm again, brachial, upper arm. Both the back and the front are called brachial. Gluteal means your buttocks. Femoral, again. This area, even though it's posterior, it's still called femoral. So both anterior femoral is the same thing, and posterior femoral, same name. Okay. Okay, this is pretty important too. This is called the popliteus. So the area or the fossa that you have behind your knee, right, is called the popliteus, the popliteal region. The popliteus is a muscle, the popliteal region. And then that's it, really. Again, I'm not saying you need to know all of this. You're going to learn all of this eventually, but yes, it can. The ones that I mentioned on this slide over here, these two slides, these can come in your exam because he mentioned these specifically. These might not come, but you still need to know them eventually. Let me erase this so we can continue. This is the last part of the first lecture, so we're almost done with the first lecture. But this is important, so you guys pay attention. Okay, so now when you have a joint, what's the main purpose of a joint? Why do we have joints? Why do we need joints? Can someone tell me? I want someone to tell me why we need joints. Exactly, we need them for movement, right? Or otherwise we wouldn't have joints. In fact, joints, like, they help in movement, but they're the weak point for the body. It's where a lot of damage happens because they're not as stable as the rest of the body. But it's a sacrifice that's worth making because we need to move, right? So one of the movements that you could have at a joint are two of the movements. These are opposite movements, are flexion and extension. So flexion is when you decrease the angle between a joint. So let me take the example of the elbow because it's the easiest to explain. This is the elbow joint over here, right? And right now the angle at this joint is 180 degrees, right? You know, a straight line, the angle is 180. Now, if I were to do this, I'm decreasing the angle. The angle is now 45 degrees. So this is flexion. I'm flexing my elbow. I can flex my neck. This is flexion. I can flex my knee, right? I'm not going to show you. I'm not going to get up, but you can flex your knee. Think of it as right now when you're in anatomical position, everything is 180. Nothing's flexed. But then if you decrease the angle, it's called flexion. If you increase the angle, it's called extension. Again, if I were to take the example of my elbow, it's flexed now, right? The angle is 45. I do this, the angle is 180. I'm increasing the angle. So this is extension. If I do this, my neck is flexed, right? Because you see the angle is low. But then if I look up all the way, the angle increases, right? So it becomes a greater angle. That's extension. My wrist is a good example. Look, if I were to do this, this is my wrist joint. And then if I were to do this, you see I'm increasing the angle between the joint. So that's extension of my wrist. Flexion and extension of your wrist. Is this clear? Great, great. Now we'll move to abduction and adduction, right? This is really easy. So you remember how I told you you have a midline? Anything that's towards the midline is medial. Anything that's away from it is lateral. So if I move something from the midline farther away, it's called abduction. If I move something farther away towards the midline, that's called adduction. Abduction and adduction. And how I remember this personally is abduction is also another word that you can use for kidnapping, or like, someone abducted me, someone kidnapped me, someone took me away. And abduction means you're taking something away from the midline, right? So that's abduction, abduction. Adduction or adduction is moving something from farther away towards the midline. So for example, I can abduct my shoulder. This is my shoulder right now, okay? If I were to do this, my shoulder is moving away from the midline. The midline's over here. The shoulder is moving away. This is abduction. Abduction of your hip, abduction of your thumb is possible. I'm in anatomical position right now. If I were to move my thumb further away, look at my right hand. If I were to move the thumb farther, all the way, I'm abducting it, right? Because I'm moving it away from the midline. Yeah? You understand that? And then adduction is moving towards the midline. Okay. So, like, again, the thumb, right? Look, this is my thumb. And then if I were to move it like this, you see this? Now I'm moving it towards the midline because this is the anatomical position of the thumb. If I were to do this, I'm moving it towards the midline. So I'm adducting my thumb, adducting my thumb, right? Okay, or if this is my wrist in anatomical position, right? If I were to do this, right? I'm moving my wrist towards the midline. So I'm adducting my wrist. If I were to do this, I'm moving my wrist away from midline. So I'm abducting my wrist. Is this clear? This is clear? Great. Okay, good. Now we have these two movements are a bit confusing. Rotation and circumduction. So rotation is honestly rotation, just remember the definition. It's moving a joint around the longitudinal axis. This is a longitudinal axis. So anything that's moving around this joint is rotation. So for example, my wrist, right? I can rotate it. This is a rotation of my wrist. Or my neck, like my neck, look, I'm moving it right or left. I'm rotating it around this longitudinal axis. The axis is my skeleton. I'm moving right, moving left. It's rotation. My shoulder, you can rotate your shoulder. Like, look, this is the shoulder. If you bring it inwards, you're rotating it inwards, internal rotation. If you're rotating it outwards, external rotation. It's not as dramatic as your neck. Like your neck, you can clearly tell, but you're still moving your shoulder inwards or outwards, internal or external, right? Circumduction, on the other hand, is moving a joint in a circular motion. Now, the best way that I can explain this to you is think of a helicopter. Basically, like, for example, if you were to do this movement with your shoulder, that's circumduction. Look, I'm moving in a circular motion, not rotation. Rotation is like this or like this. Circumduction is like this. It's a circular motion, like a helicopter, kind of like, or your wrist joint, right? This is circumduction of your wrist joint because I'm moving it in a circle, not towards the right or the left or along a longitudinal axis. That's rotation. So rotation is far more limited than circumduction. Circumduction is a lot more motion, like you're moving it in circles. Whereas rotation is right or left, you know what I mean? Like it's you can't really tell, but like circumduction is a big movement, you know what I mean? Like a helicopter, kind of. Like think of a helicopter is how I understand it. Is that clear to you guys as well? I want it in the chat, please. Yes or no? Can someone tell me yes or no? Okay, great. Okay, good. So now we have, I think the last movement, is this the last one? No, there's another one after this. Okay, so there's two more sets because all of these that I'm talking about are related to each other. So flexion, extension, or like pronation, supination, inversion, eversion, these are all a pair. So okay, again, this one, I have a really good way to remember this. So pouring soup is like you're pouring soup, right? So the first part is pour. When you're pouring something, how do you pour? Like this is a bottle of water, right? If I want to pour it, I'm going to do this, right? So this is pronation, okay? And then soup. When you're holding a bowl of soup, right? You have a bowl of soup. How are you going to hold it? You're going to hold it like this. Well, are you going to hold it like this? Are you going to put the bowl on top of this? No, right? You're going to do this. You're going to put the bowl here. I wish I had a bowl to show you guys, but like if I had a bowl of soup, I would hold it like this. So this is supination. Supination. Remember, it's soup, supination. If I were to pour something, I would pour it like this, right? This, what happens? Your hand becomes this way. This is pronation. Okay? This is pronation. This is supination. The definition is there's no proper definition for this. If you want to remember one, you can remember what's on the screen. But I'm not even going to read it out because there's no point in reading it out. They're never going to ask you what pronation is, but they might give you a picture and say, is this hand pronated or is it supinated? Right? And then you're going to think, oh, I can't hold soup like this, but I can pour like this. So this is pronation. And then if I were to hold soup, if they give you this picture, you'd say, oh, this is supination, right? So yeah, I hope you guys understand. That's how I always remembered it, and that's how I still remember it to this day. And now we have inversion and eversion. So basically, I'm not going to show you my feet, but if these were my feet, right? And let's say these are my 2 feet. I bend them in a way that the soles are facing each other. I bend them like this. This is inversion of my feet. And then if I were to bend them outward so the soles are not facing each other, eversion. So when the sole of your foot is inwards, that's inversion. And when it's outwards, it's eversion. And I'm going to show you a picture that'll make it much more clear, inshallah. Oh, wait, there's another movement. Okay, this one's really easy. Dorsiflexion and plantar flexion. So dorsiflexion is moving, this is my foot, right? And I do this, I'll move my foot upwards. That's dorsiflexion. But if I were to move my foot downwards, that's plantar flexion. So imagine if you're driving a car and you want to press on the gas, you do this, right? With your foot. That's plantar flexion. You're plantar flexing your foot. And then the opposite of that is dorsiflexion. You're moving your foot up, off the gas, okay? Let's say you're on the gas and you want to let off, you're going to move your foot up. That's dorsiflexion. If you want to press on the gas, it's plantar flexion. All right? Okay. Oh, wait, there's another one, but I'm sorry. There's another, this is the last movement for sure, right? Yes, okay, this is the last one for sure. Opposition is a special thing that only your thumbs can do. This is a movement that's specific to your thumbs. And this is something that can come in the exam. They might be like, which of the following is, specific to your thumbs, or which of the following can do opposition, right? So basically, look at me. When I do this, or this, or this, or this is opposition. So I'm touching the tip of my finger with my thumb on the same hand. So this, that's opposition. And it's unique to thumbs. So basically, now I have pictures. So let's say, like let me get the pen. So if my arms are like this, and then I move them away. So if my arms are like this, right? And then I do this, you see I'm increasing the angle between the shoulder and the body. So this angle is increasing. That means it's abduction, abduction. You're kidnapping it, you're moving it away. And then if I were to do the opposite, if my arm's like this and then I do this, I'm decreasing the angle, this angle. I'm decreasing this angle. So it's adduction, adduction. And then flexion, right? You see this angle is 180. So now I'm doing this, it's 90 or less, so it's flexion. And then if I do the opposite, it's extension. This is what I'm talking about. This is rotation. So you see here, this person is, if this is how your shoulder is normally, if you were to do this, you're externally rotating your shoulder. You're rotating your shoulder away, right? And then you have plantar flexion, you see, towards it's downwards, and then dorsiflexion is upwards. And another way that you can remember this is plantar and planet. So plantar flexion means you're moving your feet towards the planet. You're moving them downwards. Dorsiflexion is the opposite. That's another way you can remember plantar and dorsiflexion. Okay, I think there's another few pictures, maybe. Let's see. Right. So here, this is so if you can see your palm, that's supination, because that's how you hold the soup, right? And then if you can see your knuckles, that's pronation, because you're pouring something, prone, right? And then this is inversion and eversion. I hope you understand. Like when your soles are facing each other, it's in your feet are inverted, and then when they're facing away, it's everted or eversion. And then this picture at the top over here is a person touching their thumb to their index finger, and that's opposition, right? This is opposition. Okay, we're done with lecture 1. So any questions, ask me now. Any questions at all, lecture 1? Any questions? Yes or no? No. So no one has any questions. Good. Would you like 2 minutes before the next lecture, or should we continue? Like a break? No break? All right. Okay, good. Let's continue then. So we're gonna start lecture number 2, which is also by Dr. Hassan. I think he gave you the first 2 lectures, if I'm not mistaken. Okay. Right. So now we're gonna go to the types of skeleton. Just let me have a break. I want to drink water. So you can think about the types of skeleton, right? So basically, we have 2 types of skeletons. We have an axial skeleton and an appendicular skeleton. And this picture is amazing. Everything in pink is your axial skeleton, and then everything in purple is your appendicular skeleton. Okay? So your axial skeleton is what forms the axis of your body, right? You're standing upright. What's forming the axis? Your axial skeleton. So the bones in the axial skeleton are your skull, the ossicles of your inner ear, okay? So you have bones in your ear, and these are part of your axial skeleton because they form your axis. And then you have the hyoid, which is the bone over here, you have your vertebral column, right, within which the spinal cord is, and then you have your rib cage or your costal cage. Where will the recording be shared? YouTube, yeah. Okay. Yeah, so basically you have the axial skeleton, your axis, and then anything that comes from the axial skeleton, a joint that separates it, is your appendicular skeleton. So everything other than the axial skeleton. So like your axial skeleton, you have this, you have two joints, the shoulder joint. Everything after that is appendicular. You have your hip joint. Everything after that is appendicular. So your upper extremities, your arms and your hands, your lower extremities, which means your hip, your leg, your feet, everything. And then your shoulder girdle. What's the shoulder girdle? The shoulder girdle is what connects the appendicular skeleton to your axial skeleton. So this shoulder girdle, it connects it to the axial skeleton, the rest of my upper limb. And then the pelvic girdle does that for your lower limb. It connects the lower limb to the appendicular skeleton. I hope that's clear. Now, if you have now you can classify the bones based on their shape. Okay. So it's quite obvious. You have long bones and you have short bones. So if you have a bone that's longer, then it is wider. It's a long bone. If it's longer, then it is wider. So for example, you have the femur, which is in your hip. You have your humerus, you have your radius and ulna, which is over here. You have your tibia and fibula in your leg. You have the metacarpal and the metatarsal. Those are these bones, over here. These bones are long. I have pictures after this to show you this metacarpals and metatarsals. And then you have the phalanges, which are these, your fingers. They're also long bones. You can obviously tell they're longer than they're wide. And then the short bones are the opposite. Their vertical and their horizontal dimensions are equal. So they're as long as they are wide. So for example, your carpals, which are your wrist bones, they're short bones. And you'll see pictures that will make you understand. But you need to remember the examples, which bones are long bones, which bones are short bones, because this is something that will be asked. 100% will be asked. So your carpals and your tarsals. Your carpals are your wrist bones and your tarsals are your ankle bones. They are short bones, and I'll show you pictures. And then you have sesamoid bones. So bones that are within a tendon are sesamoid bones. So basically, a tendon is something that connects a bone to a bone, right? And then a ligament, wait, am I saying that? No, I'm sorry. A tendon is something that connects a muscle to a bone. And a ligament is something that connects a bone to a bone. So if you have a bone that's within a tendon, that's called a sesamoid bone. And there's only a few examples of these in the body, but the most important one and the only one they'll ask you about is the patella. And I'll show you a picture. So remember, the patella is a sesamoid bone. Then you have flat bones. The name says it. They're flat, they're thin, and they're flat. So basically, like, I don't know, like for example, this CD is thin and it's flat. So a bone that's like this would be a flat bone. And its main function is protection. So for example, your cranial bones that form your skull, they're flat bones. Your sternum, which is this part over here, is a flat bone. It's flat and long. Your ribs are flat and long, and then your hip bone is flat and long. And I have pictures of all of these to show you. Uh, then you have an irregular bone. All right, what is that? It's obvious. A bone that's not into any other category. It's not long. It's not short. It's not sesamoid. It's not flat. What is it? It's irregular. So, for example, the sacrum and the coccyx is how you pronounce it. These are part of your spinal, part of your vertebrae, and they're the last ones towards the end. I'll show you pictures. Your vertebrae themselves are irregular because they're a weird shape. They're not fit into anything else. So your hyoid, your maxilla, and your mandible. So those are bones of your jaw. So this is your mandible, and then this is your maxilla, this bone, and I'll show you pictures. And then you have sutural bones. So the skull, the skull has many bones. There's many cranial bones, right? And they're all joined together to form the cranium. So these bones are joined together by sutures, right? And these are like when you're born, you have them, or they close after you're born. But you have tiny bones within these sutures, and these are called sutural bones. And I have pictures of these as well. So now, can anyone tell me? Wait, okay. Number one. What is number one? What kind of bone is number one? Long bone. Nice. Very nice. Great. What kind of bones are number two? These bones in specific, these ones. What are they? Long. Very nice. Very nice. Very nice. What kind of bones are these over here? Long. Great. Perfect. What kind of bones are these? Short. Short. Amazing. Yes. Amazing. Those are the carpal bones. Those are short. Okay. Patella. What kind of bone is this? The patella. Sesamoid. Great. You can see here, you have the quadriceps femoris, which is a muscle. You have its tendon, and then you have a ligament over here of the patella. But you see it's within the patella is within the tendon of the quadriceps. It starts within the that's why it's called sesamoid. Okay. This bone right here. What kind of bone is this? Okay, irregular. Irregular. Is it irregular? Flat, flat. It's a flat bone. You can see it's flat. It's really thin and it's flat. It's a large bone, but it's thin and flat. Like flat doesn't mean it's going to be a perfect circle or a perfect square. It just means it's going to be flat and thin. Okay? So this is the hip bone, which has many other parts, but it's like this is the hip bone, it's a flat bone. Remember that. This bone in green over here. This one. What is this? What kind of bone is this? Flat. Hello. It's the sternum. The sternum is a flat bone. This is what the sternum looks like. These bones right here, the ribs, what kind of bones are they? Flat, right. Nice, nice, nice. Okay. Yeah. And then the temporal bone of the skull, or the parietal bone of the skull, or the frontal bone of the skull. What are they? They're flat. Yeah, they're flat bones. Perfect. So we're gonna move to the next. I think there's more pictures for you guys to look at. But one second, let me erase everything off the screen. Okay, that's it. Okay. Tell me the bone on the left. What kind of bone is that on the left of the screen? Irregular, irregular. It's a vertebrae, right? You can see it looks like nothing else. It's not long, it's not short because it has these weird curves and spines. It's not a flat bone because it's not flat. It's not a sesamoid bone, so it's irregular. It doesn't fit into anything else. Okay, good. This one. What is this? What kind of bone is this? Irregular. Nice. This is your maxilla. This is the maxillary one. So you can see it's irregular, right? There's a hole in the middle and it's up and down, so it's irregular. The one over here, irregular as well. This is your mandible. Okay, good. And then these bones labeled 1, 2, 3, 4, 5, 6, 7, 8. These ones, what are they? Are they flat? Yeah, they're sutural. They're sutural. This is your skull, right? These are the flat bones. The parietal bone is a flat bone. The occipital bone is a flat bone. But then you have these sutures that are holding these other bones together. And then within these sutures, you have these small bones 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You can read them on the screen. Those are the sutural bones. Okay, great. I think that's it for the types of bones. We're going to move on to the next part now. Let me just erase everything off the screen. Okay, now we have classification of the bones by histology. So that was by shape, remember, by morphology. Now we're moving to histology. So under the microscope, what do you see? You have a compact bone and a spongy bone. So the compact bone is the outer layer that's smooth and solid. It's covered by connective tissue and it's called periosteum. That's the compact bone, the outer bone. You know, in the cartoons, when you see the white bone, that's compact bone. Spongy bone is internal to the periosteum, so it's within the compact bone. It's deep to the compact bone, you can say, right? It's made up of mesh-like bone that isn't smooth, called tuberculae. So this bone is not like the classic white bone that's solid. It's mesh-like. It's like a honeycomb structure. You know how you have like like cheese, right? Like the classic Tom and Jerry cheese with holes in it. It's kind of like that, spongy bone. Okay? Now we have the structure of a long bone. So the long bone is the most important one. We have the diaphysis, the metaphysis, and the epiphysis. And this is a diagram that shows you diaphysis, the metaphysis, and the epiphysis. But we'll take definitions now. So the diaphysis is the main or the midsection, the shaft of the long bone. It's made up of compact bone that surrounds the medullary cavity. So within the compact bone is the medullary cavity in the diaphysis, right? So over here, the diaphysis, you see the outer part. Wait, let me. Yeah, this is the outer part. This shaft is the diaphysis. On the outer part, we have compact bone, and then inside we have the medullary cavity, right? And in the medullary cavity, we have fat and we have bone marrow. Okay, remember that. Bone marrow and fat in the diaphysis. Then we have the epiphysis. Wait, let me get this off the screen. We have the epiphysis, right? It's the expanded and rounded end of a long bone. So in the end, you see the shaft is long, and then the end is like, circular-ish, kind of. So the rounded end is the epiphysis. It's made of compact bone on the exterior, and then the spongy bone and bone marrow on the interior. So on this diagram, you can see the epiphysis, the rounded part. It's not rounded, but it's like, it's expansion. And then outside you have compact bone. Within the compact bone, you have spongy bone, and then you also have bone marrow, right? And then you have the metaphysis. Now, the metaphysis is the thing that separates the diaphysis and the epiphysis. It's the widened section of the long bone between the diaphysis and the epiphysis. So this part over here exactly is the metaphysis. So like over here, you see, this is the diaphysis, right? And then over here is where kind of the epiphysis starts. So this part is the metaphysis, the part that's between them, okay? And this is where you have the growth plate or the physis. The growth plate is present in the metaphysis and is responsible for longitudinal bone growth. So when children grow, this growth plate increases like this. And the site of this growth plate is the metaphysis. This is really important. And we need to talk a little more about the growth plate. There's specific things called the epiphyseal plate and the epiphyseal line that we'll take now, I think. Yes, okay. So this is important. This might come in your exam. So we have the epiphyseal plate and the epiphyseal line. So during childhood, you have a thing called epiphyseal plate or epiphyseal disc. Okay, you can see it in this picture over here. The epiphyseal plate, the pink thing over here. You see here, you see this? Now this is a cartilaginous disc. So it's made of cartilage and it separates the epiphysis from the diaphysis. And when this plate grows, the length of your bones increases and you get taller. So the epiphyseal plate is what makes you taller, right? But when you stop growing when you're 20, 21, actually you stop growing at 25 for males, you stop growing at 25. So there's still hope, guys. Epiphyseal line, okay? The epiphyseal plate closes and it becomes a line. So it becomes hardened. So initially it was cartilage. When it becomes hardened, it turns into bone, and then it's called the epiphyseal line. So the epiphyseal line is a remnant of the epiphyseal plate in adults. The epiphyseal plate is not in adults, it's in children. But when it hardens, it becomes a line, and the line is present in adults. And again, it does the same thing. It separates the diaphysis from the epiphysis. Yeah. So yeah, I hope you understood. Did you understand this? Can you please repeat? Which part do you want me to repeat? Can you please let me know? Exactly. Can you let me know what part you want me to repeat, Mawada? Hope I'm saying that right. The difference between them. Okay. So the epiphyseal plate is in children. Adults don't have an epiphyseal plate. And then when the child grows up and becomes an adult, the plate becomes hard and it becomes a line. It becomes the epiphyseal line. Initially, the plate is cartilage, so it can grow. But when you become an adult, it closes. It becomes a bone, and it's called epiphyseal line. Is that okay? Did you understand that? Okay. Right. So that's the difference between a plate and a disc, between a plate and a line, right? Okay. So the other bones, it's the same thing. There's compact bone on the outside and spongy bone on the inside, but there's no diaphysis, epiphysis, or metaphysis. These are only for the long bone. So the long bone has a shaft, which is called the diaphysis. It has a rounded end on each side, which is called the epiphysis, and it has the thing in between, which is the metaphysis. So that's what the other bones. This is other than the long bone. So a short bone, irregular bone, all of these. This is the structure. Now joints. What are joints? Joints, as we said earlier, there were two bones meet. Is the weakest part of the skeleton, so it is the most likely to be injured. But we keep up with we still take that because it gives the skeleton mobility. It allows us to move around. It allows us to move our joints. That's very important. If we were rigid, we'd be useless. We couldn't walk, couldn't sit, we couldn't, move our hands, anything. We'd be useless. So the joints help us move, and they're very important. Now we will discuss the different types of joints. What a pleasure. Uh, so there's so many different classifications, and unfortunately, you need to know everything. Well, um, so based on functionality, there's three different types, and this depends on how much movement the joints allow, right? So we have sign arthrosis, which are immovable joints. So these joints, they can't move, even though that's supposed to be the function of a joint. They can't move. Ironic. So sutures, right? Sutures, you can't move. If these move, then you're in trouble. So these are sign arthrosis. You need to remember the names of the joints and the examples, by the way. The manubriosternal joint, which is this one right here, is between the manubrium. The manubrium is this thing, and the sternum. The sternum is this bone. So the joint between them is not supposed to move. So it's sign arthrosis. Then you have amphiarthrosis, which is a slightly movable joint. It can move a little bit. And this is an IV disc. So this green thing over here, the IV disc is an amphiarthrosis. It's between two discs. It's between two vertebrae. And then you have the pubic symphysis, right? So the hip bone, there's a right hip bone and a left hip bone, and they're joined at the pubic symphysis. Now this is an amphiarthrosis. It's slightly movable, but not a lot. And then you have diarthrosis. These are freely movable joints. All the you don't know. I mean, you probably know synovial joints somewhat from high school, but like we haven't taken them yet in this lecture. So we're just gonna say most joints in the body are diarthrosis. They're freely movable. For example, your glenohumeral joint, which is your shoulder joint, is freely movable. I can move it. And then your radiohumeral joint, which is your elbow joint, is as well as freely movable. Your wrist, freely movable. These are all diarthrosis. Okay. Is this clear to everyone? Okay, nice. Okay, let's move on then to the next type of joints. The next type of joints are based on their structural classification, right? So it's based on how the joints are when two bones are together, they're put together. Now, how are these two bones joined together? That's what this classification is. So it can be fibrous. So if the bones are joined by fibrous tissue, then it's a fibrous joint. And these are mostly unmovable because you can't move fiber. It's fibrous, it's solid. You can't move it. These do not have a joint cavity. Okay. And I'll tell you what a joint cavity is. But there are three further subtypes to fibrous joints. Then there's cartilaginous joints. And these, as you say, they're united via cartilage. So there's cartilage. They don't have a joint cavity, and there are two further subtypes that we'll also take. And then there's synovial joints. Synovial joints are the ones that are most freely movable because they have a joint cavity that's filled with fluid. And this fluid is called synovial fluid. It helps reduce the friction. So you can easily, this is a bone and this is a bone. There's a joint cavity. This bone is within this bone. And this cavity is full of fluid, right? So there's no friction when the bones move. So the bones can move easily. That's why it's called a synovial joint. And all synovial joints are diarthrosis joints. You remember that I said that earlier? Diarthrosis means freely movable. All the synovial joints, they're freely movable. Whereas the fibrous joints, most of them are synarthrosis. They're not movable because, well, it's fibrous, it's solid. You can't move it. So we'll take now the further subclassifications. There's three for fibrous, two more for cartilaginous, and then six for synovial. So we'll take them right now. So there's the types of fibrous joints are, for example, there's three, okay? There's sutures, there's syndesmosis, and there's gomphosis. They're silly names, but So sutures are the bones of the skull. I told you like a million times already. They're between the skull. They bind the different types of cranial bones. They bind them tightly, but allow for growth diffusion in adulthood. So these are sutures. They're fibrous joints. And as I said earlier, they can't move. So, it makes sense. And you see the diagram on the top right, you can see the sutures between the two cranial bones. Then you have syndesmosis. These are bones connected by fibrous tissue ligaments. Okay. And the movement varies from immovable to slight movement. Okay. So example, between the tibia and the fibula, which are in between, which are the bones of your leg, or the radius and the ulna, the bones of your arm, they have a syndesmosis. And I'll show you a picture of this. And then you have a gomphosis. A gomphosis is, your teeth, your teeth are actually implanted into your jaw. And this joint between the teeth and your jaw is called a gomphosis. It's between the root of your tooth, which is the lowest part of the tooth, and the alveolar processes of the jaw. I'll show you a picture to make it more clear. Okay, so you see here, the first one is a suture. So this is one type of the fibrous joint. The second one is what is it called? Symphosis? I forgot myself. It's really syndesmosis, right? Syndesmosis. The second one is syndesmosis. You see this thing here that I'm marking, all of this shiny stuff. That is a syndesmosis. It's fibrous ligament that's connecting in this case, it's connecting, I think this is definitely the tibia and fibula because it's written over here. So it's connecting the tibia and the fibula. And again, the radius and the ulna also have something similar between them. It's called a syndesmosis. Then you have a gomphosis. And this thing, there's the root of the tooth, which is this part, is within the alveolar bone or the alveolar part of the jaw. So this is a gomphosis. It's also a type of fibrous joint. So do you guys understand the three types of fibrous joints? I know it's a lot, but you have to remember it. You get it? The fibrous joints clear? Okay, nice. Perfect. The last one, okay. So the gomphosis is a really funny name. I wonder who came up with it. But okay, it's basically when you have the root of your tooth, it enters the jaw. It's fixed to the jaw. So these two bones, because the tooth and the alveolar process, when they connect, this is called a gomphosis. It's a type of joint between the root of your tooth and the alveolar process of your jaw. That's a gomphosis. So is that clear? It is? Okay. Yeah, gum. You can remember it like that. That's nice. Lamar. Thank you. Right. Now we have the cartilaginous joints. There's two subtypes. Remember, these are the classifications based on how the bones are joined together. So we had fibrous, we took fibrous. There's three types of fibrous. Now we're taking cartilaginous, which is the second part. So there's two. There's synchondrosis and symphysis. I can't tell you the amount of times I confuse synchondrosis with syndesmosis. Syndesmosis is a type of fibrous joint. Synchondrosis is a type of cartilaginous joint. And a way you can remember this is chondro, or anything that has chondro means cartilage. Okay? So when you hear synchondrosis, immediately just be like, oh, this is a cartilaginous joint for sure. Okay? So synchondrosis is a primary cartilaginous joint. It's when a plate of hyaline cartilage unites the bones. Now, there's many different types of cartilage. There's hyaline cartilage, fibrocartilage, and there's genuinely maybe, I don't know, a lot of types of cartilage. But you need to remember specifically synchondrosis is hyaline cartilage. Hyaline cartilage unites the bones. For example, you have epiphyseal plates. Remember we took these? They're the things that make you grow. These are hyaline cartilage. And then the joint between the first rib and the sternum. I'll show you a picture so you understand better. These are both joined by hyaline cartilage, and they're called synchondrosis, or primary cartilaginous joint. And then you have symphysis, or secondary cartilaginous joint. This is when the bones are united by fibrocartilage, not hyaline. Hyaline is primary, fibrocartilage is secondary. So for example, your IV joints, your intervertebral joints, or your pubic symphysis, they're fibrocartilage. it's what is the difference between primary and secondary? The difference is the type of cartilage. So hyaline is primary, fibro is secondary. That's the only difference you need to know for now. Okay, Nasser? That's pretty clear. Okay. So in this picture over here, you see a synchondrosis, right? Which is a primary cartilaginous joint. You see the epiphyseal plate? This thing is the epiphyseal plate. And this is hyaline cartilage. It's in between, it's where the growth happens. I told you about this, guys. We just learned it earlier. And then we have this thing. This is also a synchondrosis. It's a primary cartilaginous joint between the sternum and the rib, the first rib. So this is a synchondrosis. Now over here, we have the secondary cartilaginous joints or symphysis. So this IV disc between the two vertebrae, these are symphysis. Or this thing is at the pubic symphysis is a fibrocartilaginous joint. So it's a secondary cartilaginous joint. So secondary cartilaginous, fibrocartilage, symphysis, all the same thing. Synchondrosis, hyaline cartilage, primary cartilaginous joint, they're all the same thing. That's as easy as it gets, which is not easy at all, but you have to remember it. Okay, good. So now we're done with the cartilaginous joint. We're going to move to the synovial joint, which is the last part of this lecture. So after this, we're done with half of the crash course. Yeah. So basically, you have the synovial joint, which is the most important one. That's why it's in so much detail. You have the structure from outer to inner. You have a ligament. So the muscle is connecting to the joint, which is the ligament. I mean, the bone, sorry, the bone is connecting to the joint, which is the ligament. And this is made of collagen. So this over here, you can see the ligament over here. This is the ligament. Then you have a capsule after the ligament. So the capsule is divided into a fibrous capsule and a synovial membrane. So you can see over here, the fibrous joint capsule is this part, and then you have the synovial membrane, which covers the synovial capsule, which covers the synovial area, right? So that's next. And then we have the articular cartilage. The articular cartilage is even deeper than the synovial membrane. And then after that, you have the joint cavity itself. So everything outside of this is what's covering the joint cavity. After all of this, you have the joint cavity. And then within the joint cavity, you have the synovial fluid to reduce the friction, right? So from outer to inner, you have ligaments, you have the articular capsule. The capsule is subdivided into fibrous capsule and synovial membrane. Within the synovial membrane, you have the articular cartilage. And then after that, you have the joint cavity and the synovial fluid within the joint cavity. Is that clear? The structure of the synovial joint, again, it's important. This can come in your OSCE, when they ask you to differentiate between in the lab, or they might ask you, this is what is this? So is this clear to everyone? Guys, a yes or no would be really nice, so I can explain again if it's not clear. Okay. Yes. The components will be in OSPE. Yeah, for sure they can be. 100%. This is something they will bring in your OSPE probably. Especially like the pictures in the lecture, which is I should explain that after this. 100%. So it's probably going to come in the OSPE, if I'm being very honest with you. So this one right here on the top is the picture that was in the doctor's slides. So this you need to know like really well. So this is the ligament. This is the joint cavity, right? This is the articular or hyaline cartilage, which is within the membrane. And then you have the capsule. The capsule has the fibrous capsule on the outside and the synovial membrane on the inside. And then the doctors also gave you this thing which is related to a real cadaver. The one on the right, this one is a real picture. So really, you guys need to go, like, you need to really understand this for sure. Remember the doctor's one, really important. And then we have the synovial joints range of motion. So there's many different types of synovial. There's 6 types of synovial joints. And some of them are non-axial, so they don't have any movement. Some of them are uniaxial, so they have movement in one plane, right? There's 3 planes. There's this plane, the X, the Y, and then the Z, right? So uniaxial means movement in one plane, biaxial means movement in 2 planes, And then multi-axial means movement in 3 planes. And there's different types of joints, and we'll go over them now. Non-axial means it can barely move. There's no movement in any plane. Okay. Let's move to the next slide now. The synovial joints are the last thing in this lecture, and then we're done with 2 lectures out of 4. So I think we're doing good. Also, the next lectures are a little easier. Actually, they're not. They're not easier, but yeah. There's different types of synovial joints, right? We have a plane joint. There's 6 types. So let's start with the first one. The first one is a plane joint. So the plane joint is it allows for only slipping movement. So it's not even real movement. It's just like slight slippage, you know. And both the articular surfaces, both the bones, they're flat. They're flat bones, and they're only slipping. There's no real movement. That's why they're non-axial joints. So an example is the acromioclavicular joint, which I'll show you examples of everything, don't worry. Or the joints between the carpals in the wrist or between the tarsals in the hand. They're all examples of synovial joints. So both the surfaces are flat and they're slipping against each other. Right. And then we have the hinge joint, which is the next type of joint. So you have a cylindrical projection, okay, from one bone that's fit into a choke in the other bone. So like this kind of, you know what I mean? These joints are uniaxial and they only permit one type of one movement in one plane. And this is flexion and extension. So your elbow joint or your interphalangeal joint, they're hinged. By the way, you need to remember the examples of the plane joint, the hinge joint, all of this. This will come probably as well. So the hinge joint, for example, interphalangeal, this is the hinge joint. You see, flexion, this is flexion, extension. Flexion, extension, section. Okay. And then we have a pivot joint. This is when the rounded end of one bone fits into a sleeve formed by the other bone. So you have a rounded end fit into a sleeve, kind of like this. And this sleeve can be made by the other bone and ligaments. So the ligaments can help in the formation of this sleeve. So these joints are also uniaxial. An example of this is the radio-ulnar joint, which is the joint between your radius and your ulna, or between your axis and the dens. These are, I'll show you pictures. It will be much more clear. But remember for now, pivot joints, rounded end, fit into a sleeve, hinge joint, cylindrical into a trough, and then plane joint is just slipping against each other, right? Now we have a condyloidal joint, okay, or an ellipsoid joint. So this is when an oval surface of one bone fits into a complementary depression on the other bone. So you have an oval, and then you have a depression in this bone, and this fits into this. Perfect. These joints are biaxial, which means they move in 2 planes. So for example, radiocarpal joint or your wrist joint, one of the wrist joints, okay? It can move in 2 planes, right? Because it can do this, right? And then it can also do this. So it can do this movement in this plane, and then this movement, right to left, which is in this plane. So 2 planes, right? And then your metacarpophalangeal joints, which are the joints between your phalanges or your fingers and the metacarpals. So these joints, you can move it, you can move your fingers, right? You can move them this way. You can also do this. So two planes. So condyloidal or ellipsoid joints, 2 planes, and they're this way, right? Oval into the depression. Saddle joints, they're similar to condyloid, but they allow for a greater range of motion. So they're similar, but greater range of motion. So this you will understand better on the picture. So I'm going to save it for the picture. This, it's, for example, the carpo-metacarpal joint. So the joints between your carpal, which is your wrist, and the metacarpal. This is a condyloid joint. Same, biaxial, but you can move these more freely than the condyloid joints, you know? There's a greater range of motion. Ball and socket joints are the pinnacle of joints. They're multi-axial. They can move in any plane, all 3 planes. They can move in all 3 planes. For example, your shoulder joint, you know, it can move in 1 plane, 2 plane, and then 3 planes, all 3 planes. Your hip joint is the same. It can do both. So ball and socket, three planes, or multi-axial, if you want to call it multi-axial. Now we'll move to the pictures, and I will ask you guys to tell me what kind of joints we're looking at in the pictures. Okay, so first of all, before we move to anything, this is a okay. This is a wait, where did it go? Yeah, okay, here we go. So these are for example, a ball and socket joint looks like this. You see? It's like there's a ball and then there's a socket and it fits perfectly. Then you have a condyloid Remember the condyloid? It's when you have a depression and a sphere, so it fits. A plane joint, it's flat bones rubbing against each other. A saddle joint is like the condyloid joint. It's similar, but it has more range of motion. And I'll show you why. A hinge joint is when you have a cylindrical thing fitting into a trough, right? And then a pivot joint is when you have a sleeve and then the rounded end fits into the sleeve. Okay. So now, number one, what kind of joint is number one? What kind of joint is number one, please? A plane joint. Good job. It's a plane joint. And this is the carpal joint. So these bones, these small bones, these small bones, they rub against each other, right? They rub against each other, but they don't really move that much. So this is the example of a plane joint. And you have similar in your foot, the tarsals, they look the same pretty much. And then you have this joint. What kind of joint is this? The AC joint, a acromioclavicular joint. Yeah. What kind of joint is the acromioclavicular joint? Someone answer, please. Okay. I have in the chat someone said ball and socket. Do you have any other answers? Can anyone else want to answer before I answer? Plane. Yes, it's a plane joint. So this AC joint is not the shoulder joint. It's the joint between the acromion and the clavicle. These are bones, right? It's you don't need to know the bones now, but just remember this joint, the AC joint, is a plane joint. There's only slipping between them. There's no real movement. That's why they're plane joints. So let's move to the next one. There's a lot more questions for you guys to answer. And yeah. Okay. Oh, damn, bro. All of them have answers. So not really a challenge, is it? If there's answers everywhere. Okay. So this is a hinge joint. Can someone give me an example of a hinge joint in the comments? Elbow. Nice. Elbow is a hinge joint. Yes. Okay. So the elbow is a hinge joint, and it's pretty obvious. There's a cylindrical thing. It goes in flexion, extension, uniaxial, only one. Okay, great. I'll ask you guys a question now. There's a joint between the radius and the ulna. What kind of joint is that? The radio-ulnar joint. Can someone tell me? Pivot, exactly. The pivot joint. Exactly. The pivot joint is the joint where you have a sleeve and then you have the rounded end. Okay, you're gonna see another picture. I think there's another picture after that makes it more clear. Okay, so the interphalangeal joints. What kind of joints are the interphalangeal joints? Someone answer. Hinge, perfect. Yeah, because they can do flexion, extension, right? In one uniaxial, uniaxial. The metacarpophalangeal joints. What kind of joints are the metacarpophalangeal joints? Condyloid. Okay. Yes, that was mentioned earlier. And then we'll move to the next slide now because there's still one more thing I want to explain in these kind of joints before we move to the next part of the this thing. Okay, so this joint on the left side, can anyone answer? Tell me what kind of joint this is. The one on the left, pivot joint. Excellent. So this is the joint between the axis and the dens. The axis is C1. The vertebra C1 is called axis, and the joint that it forms is a pivot joint. So only left or right. And the joint on the right side, what kind of joint is that on the right side? Yeah, it's also a pivot joint. No, it's not ball and socket. Because let me show you. So you have this wait. You have this thing. This is forming the sleeve, and then you have the rounded part within the sleeve. And when you have a sleeve and a rounded part, what is it called? It's called a pivot, right? It's not a ball and socket joint. Yep. Okay, good. It's okay to make mistakes. Right. So that's it. We move to the next one. There's more. There's more. The one which is on the left of the screen. What kind of joint is that? This one over here. The left on the left. This one. Condyloid. Yes, it is a condyloid joint. Okay. What's the one? What's this joint? Wait. This joint right here. The carpal metacarpal joint. Can someone answer? The one that I circled? It's a saddle joint. Perfect. So a saddle joint is a variation of the condyloid joint with more range of motion. Okay. And then lastly, the one in the center, what kind of joint is that? It's the same picture actually. Okay, it's still a saddle joint. Yeah, it's the same picture. Now I want to explain to you guys the difference between a saddle joint and a condyloid joint. Okay. And for that, I'm going to use these two pictures. This one, because this is condyloid, and then this is the saddle joint. So in the condyloid joint, you see the lower bone is curved like this, and this is called a concave, okay? And then the upper bone is this way. So it's convex. So the upper bone is convex and the lower bone is concave. And when you see this is a condyloid joint. On the other hand, over here, you see it's not like this. One part is like on the lower bone, you see, it has this, and then it also has this. So there's two curves. One's like this, and then there's one like this. It's hard to imagine, but if you try, you understand that there's two curves. There's one like this, and then one like this. So in the saddle joint, there's a convex and a concave curve on both bones. So both bones have a convex and a concave curve. And this is why they have a greater range of motion when compared to condyloid. Do you guys understand this? Condyloid is similar to ball and socket. I mean, not really. I'm sure they might look similar, but they're not. No one's going to tell you that they're similar. Not in the motion. I know you mean not in the motion. Looks wise, maybe, yeah, sure. Can you repeat why it has a greater motion? So the condyloid joint has either convex or concave surface. One of them is concave, one of them is convex. So they fit like this. Okay. But the saddle joint has both surfaces are convex and concave at the same time. So they're like, I can't do it with my hands, but you know, the surface, one part of the surface is like this, okay, and the other part is like this, okay? But both of the surfaces are convex and concave at the same time. Subhanallah. That's how their range of motion is greater. Did you understand that, Reem? Okay. And you can say like it might look similar. The condyloid joint might look similar to the ball and socket, but they're not similar at all. And I would recommend that you don't think of it that way because you might get confused. But remember, condyloid and saddle, how do you differentiate them? They have concave and convex. Concave and convex is condyloid. I mean, concave for one and convex for the other is condyloid. Concave and convex, both of them is saddle. Okay? And the saddle has more range of motion. Remember the examples as well. They're really important. They're going to ask you the examples for sure. Okay, let's move on to the next one. Okay, these are all ball and socket joints. I'm not even going to explain this because everyone knows this. Ball and socket. It's the easiest thing in the world, right? Ball and sockets. Easy. Okay, let's move on to the next one. So we have three types of muscles. We have skeletal muscle, cardiac muscle, smooth muscle. Skeletal muscle are voluntary, which means we can control them, and they're the most common. They can be fatigued due to large amounts of contractions. So, you know, if you work out at the gym, for example, you can get fatigued because you're, working out your skeletal muscle, and you're running, or anything, swimming. They're supplied by somatic nerves, and we'll learn about the different types of nerves later. And then you have cardiac muscles. These are involuntary, so you can't control them. You can't tell your heart to stop beating, right? They're present in the heart. They're supplied by autonomic nerves, which means, again, we'll learn the different types. Forget the nerves for now. Somatic, this cardiac or involuntary, skeletal or voluntary. The contractions are fast, strong, and rhythmic, and they do not get fatigued, okay? Your heart never stops until the day you die. So they do not get fatigued. Smooth muscles are also called visceral muscles. Viscera means inside or like within your body, like something that you can't control. So visceral. They're also involuntary, you can't control them, and they're also supplied by autonomic nerves, right? The contractions are slow, sustained, and rhythmic. So the difference between cardiac and smooth is cardiac contractions are fast, okay? Because your heartbeat, what's the normal heartbeat? What's like a normal heartbeat? Can someone tell me? 75, yeah, that's a normal heartbeat, around 75. So 75 beats per minute means more than one beat per second. So it's very fast, right? It's rhythmic, it needs to be in order. It can't just like do this and then slow down and then, that's not rhythmic. The smooth muscles contractions are slow. They're slow and controlled. And again, they do not get fatigued either. So both cardiac and smooth muscle, no fatigue. Where are the smooth muscles found? They're found in the walls of vessels. So in your arteries, and in your veins, and in organs as well. The walls of organs also have smooth muscle in them. So let's move on to the next slide now and understand the differences between the three types of muscles. So skeletal muscles are attached to the bones. Smooth muscles are in blood vessels, in hollow organs, in glands. Cardiac muscles are in the heart. Skeletal muscle is striated a lot. Cardiac muscle is slightly striated, and smooth muscles are not striated at all. What are striations? And that's why I put this picture for you. You see this over here? This is smooth muscle. You see no striations. Striations are something are this way. You know what I mean? When you see this is a striation. It's because of the different orientation of the fibers. This is a skeletal muscle. You see how many striations there are. You can see it. You see this? You see how many different striations you can see. And then the last one is cardiac muscles. You can still see the striations, but they're not as obvious as the middle one. The middle one is skeletal. The one lower is cardiac. And the one at the top is the smooth muscle. This has no striations at all. In the smooth muscle, all the muscle fibers are going this way. So there's no striations. In the skeletal one, there's a lot of striations. So they're going this way, you see? And then cardiac, there's slight striations, but less. The nucleus in a skeletal muscle, there's multiple peripheral nuclei. So you see here, these are multiple nuclei at the same place. In smooth muscle and cardiac muscle, you have a single nucleus and it's at the center. So single central nucleus. The skeletal muscle is controlled somatically, so it's voluntary, which means your brain can give a command to move your muscle. So if I tell my brain I want to move this, it's going to move. The smooth muscles and the cardiac muscles are autonomic, which means they're involuntary. Your brain doesn't directly control them. It's controlled by itself. You don't have to think about it. It's autonomic. So the functions of skeletal muscles is movement, smooth muscle, it compresses the tubes and the ducts. So for example, the smooth muscle compresses an artery. What's going to happen? Your blood pressure is going to increase because the artery is getting narrower, right? So your blood pressure is going to increase. Similarly, the cardiac muscle is responsible for heart contractions. The cell type for skeletal muscle is a cylindrical cell. So the cell, if you zoom in under the microscope a lot, one cell is going to look like this. Whereas a smooth muscle cell is going to be spindle shaped, which means it's going to look like this. Okay. Spindle shaped. And then cardiac muscles are branched. Cardiac muscles are actually connected to each other. So each cell is connected to each other. They're branched. They're the only type of muscle in which you can see this. So yeah, that's it for the muscle types. I think there's just a few more things and then we're done with the lecture. Right, wait, how many? Okay, we still have a bit before the lecture is finished, all right? We're gonna finish this lecture, then we can take a break so we can all recharge and be ready for the next two. lectures. So skeletal muscles have different parts. There's a fleshy part, which are called heads or bellies. You know, for example, you have, you know, why you call them the biceps? It's because they have two heads, bi, triceps, three heads, tri. And then you have a non-contractile portion called, there's different non-contractile portions. They're fibrous, they're not fleshy. These are tendons, raphe, and an aponeurosis. So I gave you an example here of, now a really important thing we need to talk about. These slides, they'll send them to you. G&D will send them to you as soon as the session's over. So origin versus insertion. So this is something that confuses a lot of people. This is why I want to make sure that you guys understand it. So you have the origin is the fixed, immovable attachment point. So a muscle is attached to, usually a skeletal muscle moves across a joint most of the time. So when it moves across a joint, when the muscle contracts, it can move the joint. Okay. So, for example, we have the origin. The origin is the fixed and immovable attachment point of a muscle. So the muscle has two attachment points, right? One where it attaches and then one another one, right? So where it attaches and that part is immovable is called the origin. And then the part where it's attached and that part is movable is called the insertion. So for example, when the muscle contracts and this part moves, this is the insertion because it's movable. And then this part is the origin because it's not moving. So for example, you have the brachialis muscle. Okay, the brachialis muscle is the main flexor of the elbow, right? So it's a muscle that's present under the bicep. So the brachialis muscle originates on the humerus. Here's the picture that I got for you guys. This is where it originates, okay, on the humerus. And then it inserts here on the ulna. So now what happens when you flex your elbow? You see this is happening. Your ulna, which is present over here, is moving. So the ulna is the insertion. That's the insertion point. Whereas the humerus, you see, the humerus is not moving. I can flex as much as I want. The humerus is not going to move. It's at one place. It's not going to move. So that part is the origin. And then the part that's moving is the insertion. So again, the insertion is on the ulna moves. The origin is on the humerus does not move. Okay. And then I gave you an example of this. This is the bicep, for example. It has a tendon. The tendon is not muscular. It's a fibrous part that connects the bicep to the bone. So that's the tendon. And then again, you have another tendon all the way over here. You see, again, you see the bicep where it connects. It connects on your lower arm, and it comes from your upper arm. So the main function, the bicep also helps in flexion. It also helps in pronation. So when you flex again, you see the upper arm is not moving at all. The lower arm is moving, like you see, it's moving up and down. The upper arm is not moving. Then you have an aponeurosis top left. This is an aponeurosis. An aponeurosis is a tendon is usually ropey and like a rope, but an aponeurosis is a tendon that's long and flat. Okay, and there's a bunch of places where you have an aponeurosis. For example, you have an aponeurosis in your palm. You have one in your lower back. You have one here in this, where your abdominal muscles are, and then and then this thing is over here on the top right is this you see this line I'm drawing? This kind of structure is called a raphe because it's when two different muscles develop and then they join together and on the midline, that's called a raphe. And this happens because embryologically they develop separately, but then they fuse. So it forms this beautiful line, which is the midline, and then you see they're symmetrical. That's called a raphe. And then I have a slide after this where I explain all of this. So you can wait. You see here? Let me just erase everything off the slide. You have the tendon, the aponeurosis, and the raphe. The tendon is a cord rope-like that insert where the muscle, which helps the muscle insert, right? Like you see the one on the top over here. That's the tendon. It's rope-like. And then aponeurosis is a tendon that's broad and flat, which is in your back, in your palms, in your abdominal muscles near them. And then the raphe is when fibers from two halves of the muscle. So it's the same muscle. is just two different halves of it. They develop differently embryologically, they develop separately, and then they fuse to become one muscle, but they're two different halves. And these, they form a beautiful structure where it's completely symmetrical, and then you have this like line in the midline because of where they fused. Now we're going to classify the different types of muscles. Before we move on to that, does anyone have any doubts? Anyone have any doubts, please answer. Okay, good. So I told you about the muscles, right? There's skeletal muscles, there's cardiac muscles, there's smooth muscles. These are based on their function, what they do. But there's different ways of like, classifying the skeletal muscles based on many different things, which we're going to see now. There's genuinely so many things you can classify them based on. So the first thing is whether they have parallel fibers or oblique fibers. So you see the orbicularis oris, it has parallel fibers. The fibers are parallel to each other, but they're circular. So they're circular parallel fibers. Then you have convergent parallel fibers, which means the fibers are parallel, right? But then they converge to a single point, which is the pectoralis major. It starts from over here, and then it converges. Opposite. Actually, it starts over here, and then it converges and attaches somewhere over here. Okay. You have fusiform parallel fibers, which means it's like spindle shaped kind of, it's like narrow and then it becomes wide and then narrow again. So like narrow, wide, narrow. This is spindle shaped, which is the biceps. These are fusiform parallel fibers. And then you have just plain parallel fibers, like purely parallel. That's a sartorius. So in case you're wondering, the orbicularis oris is a muscle that's around your mouth. So it's around here. The pectoralis major are your pecs, so they're on your chest. The biceps brachii are on your arm, and then the biceps and then the sartorius is over here. It's on your hip. It's called the smiling muscle because it looks like it's a smile, right? And then you have oblique fibers, which are not parallel. Oblique means they're in different. They're not parallel to each other. They're converging from each other. So you have a multipennate muscle like the deltoid. The deltoid has three different fibers: anterior fibers, parallel fibers, and then rear fibers. So, sorry, anterior, lateral, and rear fibers. So these are different in different directions. That's why it's called multipennate oblique fibers. And then you have the rectus femoris is another muscle. These are not parallel, they're oblique, they're in different directions. And then you have the extensor digitorum longus, which is this muscle over here. It helps you to extend your toes. This is unipennate, and multipennate means there's like three different orientations for the fiber. Bipennate means two different orientations. Unipennate means a single orientation, but they're not parallel to each other. They're just going in like weird directions, right? Yeah. So that's it for parallel and oblique. Did you guys understand this? Uh, did anyone need any help? Okay, good. Nice. Okay. Mm. So now you can shape them. You can classify them based on their shape as well. So that was based on how their fibers are arranged. This is based on their shape. So for example, you have the trapezius, which is the muscle in the back. You've heard of trapezius, the shape in school. So it's named just because it looks like that. The serratus anterior is named because it has like a sharp jaw-like pattern, sharp pattern. So it's called the serratus anterior. Then the orbicularis orbit, orbit is circular. That's why it's called orbicularis, based on the shape. And you need to remember how they're named because this will come probably. So you can see this is circular. You can see over here, this big muscle is the trapezius because it's shaped like a trapezius. And then this is serratus because it's like sharp and like, it has edges. So it's called serratus, remember. Then based on the number of heads, you can classify muscles based on how their number of heads they have. So the biceps brachii, they're called biceps because they have two heads, a long head and a short head. The biceps femoris are named because they have two heads. These are muscles in the hamstring, you know, and they have two heads. That's what they call biceps as well. Triceps, they have three heads. They have a short head, a long head. No, they have a long head, a lateral head, and a medial head. Okay, so you can see that over here. These are triceps. They have three heads. That's what they call triceps. And then you have quadriceps. Quadriceps have four heads. That's what they call quads, the quadriceps. There's four heads. There's the rectus femoris, which is on top. There's the vastus intermedius, which is under the rectus femoris. And there's the vastus lateralis, which is lateral. And then the vastus medialis, which is medial. These four make up the quadriceps. That's why it's called quad, because four. Is that clear? And then you have the muscles based on growth structure. So they have a semitendinosus and semimembranosus. These are also muscles that make up the hamstrings along with the biceps femoris, two heads of the biceps femoris. So it's called the semimembranosus because its tendon is thin and long, literally, because its tendon is thin and long. That's why they call the semimembranosus. So the tendon is like thin and long. So it reminds them of a membrane. So they call it semimembranosus. Semitendinosus, the tendon is long and like long and thick-ish. So they called it semitendinosus because it reminded them of a tendon, the semitendinosus and semimembranosus. These are the two other parts of the hamstrings other than the biceps femoris. And then you have nomenclature based on the location of the muscle. So yeah, if you have a muscle, for example, that's on your temporal bone, that's called the temporalis. This muscle right here, this is the temporalis muscle. You have the scapula. You know, the scapula has a thing called the scapular spine. So the muscle that's present beneath the scapular spine, which is this muscle over here, is called the infraspinatus because it's below the spine, inferior to the spine. Then you have the supraspinatus, which is superior to the spine, right? That's why it's called the supraspinatus. You have a muscle that's called subscapularis. This muscle is underneath the scapula, so it's called subscapularis. So all of these muscles are named based on their location. Then there's other muscles that are based on the heads, based on, you know, their growth structure, how they look like. So there's a lot of ways in how which muscles can be named. And then I think this is like the last two slides, and then we're done. I'm really sorry it's taking so long. So the based on attachment site. So if a muscle attaches on the coracoid process and the brachialis, it's called the coracobrachialis, which is this muscle. You have a coracoid process on your scapula. So it originates from there and it goes to your brachialis. So it's called the coracobrachialis. You have a brachioradialis, which it attaches to the insert to the radius and it comes from the brachial part. So it's called brachioradialis. And it's this muscle right here. You can see it's going to the radius and coming from the brachial part. Then you have the sternocleidomastoid muscle. So sterno means sternum, cleido means clavicle, and then mastoid is a thing that you have in the skull. It's a process. So it attaches to all three. That's why it's called sternocleidomastoid. So it attaches to the sternum, the sternal head. You have a clavicular head, and then it goes and attaches to the mastoid process. So that's why it's called sternocleidomastoid, based on attachment sites. And then the last type is the nomenclature based on function. So these over here are flexor muscles of the forearm. They help you flex your forearm, you know? And then you have extensor muscles of your forearm, which are these ones over here. So the flexor muscles help you flex. Flexor carpi ulnaris means it helps you flex. These muscles help you flex your fingers, not your forearms. My bad. So flexor carpi ulnaris helps you flex your ulnar side, your pinky finger. Okay. Extensor carpi ulnaris helps you extend your pinky. All right. And then you have extensor carpi radialis, which helps you extend some of the fingers on the lateral side of your body. You don't need to remember what it does. I'm just explaining to you that the muscle is named based on the job it does. So if the muscle extends, it's called an extensor. If the muscle flexes, it's called a flexor. So basically, the only thing I want you to remember from all of this is uh, how the muscles are named. Are they named based on their shape, like the trapezius? Are they named based on their function, like the flexor carpi radialis? Are they named based on their attachment site, like the coracobrachialis? Are they named based on the fact that they have parallel fibers that are circular, like orbicularis oris? Are they named based on the fact that they have multi-pinnate fibers? There's so many different things on which they can be named, and I want you to remember them. Unfortunately, it's quite important. And then I think this is the last thing. Ooh, this is the second last thing. Do we have to memorize? Oh, yeah, you need to memorize the examples, unfortunately. Okay. Uh, you need to memorize everything. I'm being honest with you. They're gonna ask. They might ask you, how is the uh, trapezius named based on its shape? How is the rectus abdominis shaped based on the direction of its fibers? So you need to remember this. So the rectus abdominis is this muscle over here. Wait, this muscle, right? And it's called the rectus abdominis because its fibers are going straight down. Rectus abdominis. And then you have this muscle, it's called the transverse abdominis because its fibers are going transverse. That's as simple as it is. And then you have some muscles that are shaped based on the size of their fibers. Or because there's many muscles in the same place that perform a similar function, but they're different sized. So the most important example, and I think the only one, Saraha, is this gluteus maximus, gluteus medius, and gluteus minimus. So the maximus is the biggest one. That's why it's called the maximus. Medius is the smaller one. It's called medius. And then the minimus is the smallest. It's called gluteus minimus. So these three are named based on the relative size of their fibers. Again, please remember this, guys. And then the last thing that we have is this. We just this. Let me just erase this off the screen and we'll be done with it in a minute or two at most. It's very, very easy because you don't have to remember any examples. You just understand what's going on. So muscles, we named them based on a bunch of things, based on their shape, based on their size, based on how many of them there are, their heads, based on, a bunch of things. But we can also classify them based on what job they do, their function, okay? So some muscles are agonists. They're the prime movers. So if, for example, I flex my elbow, the agonist, the main muscle is the brachialis, okay? The brachialis is the main muscle that's helping in this movement. So it's the agonist. The most powerful muscle providing the most force is the agonist. The antagonist is a muscle that opposes the agonist to provide smooth movement. And the reason for this is if I were to suddenly do this, it's not going to be a smooth movement, right? If instead, while doing this, I had another muscle that's opposing this movement, that's an antagonist, it's going to allow me to make this movement controlled. So an antagonist opposes the effect of a prime mover. So for example, if you're doing a movement such as flexion or pronation where biceps are helping, then your triceps are the antagonists, right? Then you have synergists. Synergists help the agonist by providing a little extra force to make the movement a little more, to make it easier. It's not putting all the force on one muscle. So a synergist is a muscle that helps the agonist. So it reduces unnecessary movement within the joints, makes it smoother again, makes it more efficient. But a synergist basically helps the prime mover. It's an assistant to the agonist. Then you have a fixator. Fixators are a group of muscles which stabilize and provide a fixed base to the proximal part of the limb so the prime movers can act more efficiently. Basically, the fixators help stabilize the movement, they're making the movement more stable. The antagonists are making it smoother, the synergists are making it more efficient, and the fixators are stabilizing the movement. Another thing that you need to remember is that the agonists and antagonists are present on opposite sides of the joint. So for example, the biceps and the triceps, they're antagonists. So the biceps are present anteriorly, the triceps are present posteriorly. So they're present on opposite sides of the joint. And this is true for every agonist and antagonist pair. So do you understand all of this so far? Can I get someone to say yes? Great. And that's pretty much it. We have one last thing. So basically, the nerve supply for skeletal muscles is a somatic nerve. A somatic nerve is a mixed nerve. A mixed nerve is a nerve that has both motor parts and sensory parts. So the motor part of the nerve means it can go and do and cause the muscle to contract and the muscle to do a function. The sensory part means that it can pick up a sensation and then take the sensation back to be analyzed. So the motor fibers are myelinated and efferent. Myelination, we'll learn about. Actually, you know what? We're going to cover all of this in the next lecture, so I'm not going to go over this now. That's basically it for the first two lectures. I've covered everything the doctor mentioned and more. So now we're going to take a break. It's 9 o'clock. I'll see you at 9:10. Is that all right, guys? 9:10, I'll see you guys. So I've been informed that we're not going to do lecture 3, which is organ systems 1. That's going to be covered in another PAL session for you guys. So we're going to go straight to lecture 4, which is a good thing, honestly, because lecture 3, Deras was going to take like an hour by itself. And I think you guys are already tired considering it's 9 o'clock. So let's go ahead and skip to lecture 4, which is a lot easier than lecture 3, and it's a lot shorter. Okay, lecture 4, let's get started. Bismillah. So the first organ system that we'll be talking about now is the cardiovascular system. The cardiovascular system has the heart and the blood vessels. Easy. The heart pumps the blood vessels are carrying the blood. And the blood has oxygen, it has nutrients, it has waste products, including carbon dioxide, it has hormones, it has defense elements such as the cells of the immune system, uh, and other cells involved in wound healing, such as platelets. So all of this is present in the blood. The blood is the media that the body uses to transport all of these to different areas. So the heart, let's talk about the heart. The heart is a 4-chambered organ that pumps blood to 2 separate circuits, the pulmonary circuit and the systemic circuit. So there's 2 circuits, right? And there's a lot of animals that don't have 2 circuits, but us as humans, we have 2 circuits. So the pulmonary circulation and the systemic circulation are separate. The blood in each never touches the other. And this is very important because we want oxygenated blood to have enough oxygen to sustain us. And when it becomes deoxygenated, then khalas, you like move. And yeah. It's so how does the heart decide what beats it should move at? Like the heart, let's say your heart's moving, your heart's beating at 90 beats per minute. What tells it to beat at 90 beats per minute? It doesn't think of it itself, or neither do you tell it to beat at 90 beats per minute. It's by the autonomic nervous system. So basically, you have the sympathetic and the parasympathetic nervous systems, and these tell the heart what frequency to beat at. They control a specific part of the heart called the sinoatrial node, which is present somewhere on the right atrium. So once it tells this node, hey, you need to be at 85 beats per minute, the node sends an electrical signal that corresponds to the same frequency. All right. So it's controlled by the nervous system, basically. So the heart has an epicardium, a myocardium, and an endocardium. So the outermost layer of the heart is called the epicardium, which covers the heart from the outside. It's like tough and a fibrous layer. Then you have a myocardium, which is basically the heart muscles and the covering of the heart muscles. Then you have the endocardium. The endocardium basically coats the surface of the inner chambers of the heart are coated by the endocardium. So you have 4 chambers. You have the right atrium, the right ventricle, the left atrium, and the left ventricle. And I have a picture on the top right, which was in your slides, and it's a really nice picture because you can really tell where uh the chambers and stuff are. So you see here the larger ones, which are inferior. Remember, we learned that like an hour ago. Inferior, superior. So the inferior chambers are the ventricles, the right ventricle and the left ventricle. And in the superior chambers are the right atrium and the left atrium. So between the left atrium and the left ventricle, you have a valve called the mitral valve, also called the bicuspid valve because it has 2 cusps. And then between the right atrium and the right ventricle, you have the tricuspid valve, which is called the tricuspid because you have 3 cusps, right? So it prevents the backflow of blood when the ventricles are contracting, because they contract so forcefully, you don't want the blood to go back into the atrium. You want it to move forward. And then the left ventricle has the aortic valve, and the right ventricle has the pulmonary valve. These are valves so that the blood only goes into the circulation when you want it to. It doesn't go all the time. Right. So let's move on to the next slide now. This was pretty basic, I would say. Right. Now we'll talk about the systemic and the pulmonary circulation. So these 2 types of circulations. Now we can think of this in 2 ways. We can start with the deoxygenated blood, or we can start with the oxygenated blood. Both of them are right, because this circuit, it's a circuit. It goes in circles. So no matter where you start, it's gonna end the same way. But we're gonna start with the lungs, okay? So you have deoxygenated blood going to your lungs. When the deoxygenated blood reaches the lungs, the carbon dioxide diffuses out, because there's a lot of carbon dioxide in deoxygenated blood. It diffuses out, and in the lungs, when the lungs, you breathe in oxygen, the oxygen is going to be exchanged with the carbon dioxide in the lungs, in the alveoli, the alveoli. So then now you have oxygenated blood in the lungs, right? So the lungs are gonna send this oxygenated blood to the left atrium. Now this blood is in the left atrium. The left atrium contracts. The blood goes to the left ventricle because of the opening of the bicuspid valve. Now the blood is in the left ventricle. The left ventricle contracts. The aortic valve opens. The blood goes to the aorta. The blood goes to the aorta. It goes to the rest of the body. This is oxygenated blood. It goes to everywhere in the body. All right. Now, in the body, when it goes in the body, it goes through, first of all, the aorta, and then big arteries, and then smaller arteries, and then arterioles, and then capillaries. The capillaries are the smallest ones, right? The walls in the capillaries are so thin that the nutrients can diffuse across the wall into tissues. So now, when you have this capillary and it's surrounded by cells, the nutrients are going to diffuse into the cells, right? And the cells, in turn, are going to diffuse their waste into the capillaries. Now, the capillaries join up and they form venules. The venules form veins. And now these veins, they have no oxygen, because the oxygen was used up by the cells. When the capillaries, the oxygen was used up. The cells in turn diffuse the carbon dioxide and waste into the capillaries and then the venules. So now these veins, which are formed from the venules, they have waste, they have carbon dioxide, they have toxins and other stuff like that. So these veins, what do? They join up. The veins that are below form the inferior vena cava, and the veins that are above form the superior vena cava. The superior vena cava and the inferior vena cava drain into the right atrium. The right atrium contracts, the tricuspid valve opens, the right ventricle, all the blood goes to the right ventricle. The right ventricle contracts, the pulmonary valve opens, all the blood flows towards the lungs. And now we're at where we started. We started at this point. We started with the deoxygenated blood going to the lungs, and now we're back at this point. So this is everything. This is the entire circuit. The pulmonary circuit is from the right ventricle, when the blood goes, and then it goes to the left atrium. So, or if I were to underline it, this entire part is the pulmonary circuit. For when the blood goes from here, here. In the lungs, it diffuses, gets oxygen, leaves the carbon dioxide, so the lungs can exhale the carbon dioxide, comes back, enters the right atrium, done. That's the pulmonary circuit. Now, the systemic circuit is the left ventricle. The blood leaves the left ventricle, becomes the aorta, becomes arteries, becomes arterioles, becomes capillaries. Capillaries diffuse with the cells. Okay, diffusion done. Now, all the oxygen is done. Now there's carbon dioxide, toxins, waste from the cells. This goes back, becomes venules, becomes veins, becomes bigger veins, becomes the vena cava. The vena cava enters the right atrium, okay, and the right atrium to the right ventricle. This is systemic. So that's pulmonary, which I told you at the top, and then the one at the bottom is systemic circulation. And in this diagram, this is a really good diagram, and I hope you understood my explanation. Did you understand the explanation? If you did, I want a yes, please. Now, please. If you didn't, tell me no, and I'll explain again. So, yes or no? Yes, nice. Can someone else also say yes? Good, nice, okay. I'm glad you guys understood it. So now there are different types of blood vessels that are used that participate in this. So there are 4 types. There's arteries, veins, capillaries, and sinusoids. So arteries, okay, we'll learn about all of these, but just in general, arteries carry oxygenated blood. The only exception to this is the pulmonary artery. the pulmonary artery is the one that's connected to the right ventricle. This is an artery, but it carries deoxygenated blood. This is an exception. This is the only one in the body. Veins generally carry deoxygenated blood. The only exception is the pulmonary vein. The pulmonary vein is the one that enters the left atrium. So this is a vein, but it carries oxygenated blood, and this is the only exception. Capillaries are the really, really small vessels, which are so thin that you can diffuse oxygen and carbon dioxide and other stuff from them into the cells. And then the cells can diffuse the toxins and the carbon dioxide into the capillaries, okay? And then you have sinusoids. Sinusoids are basically openings. They're not even vessels anymore. The vessels just have such large, the technical word is fenestrations, but I don't think you guys know what that means. So they have such large holes in them that the blood just pools out. It just goes everywhere. And this is mainly in the liver, okay? So what do the blood vessels do? They carry blood from the heart to the lungs for oxygenation and removal of carbon dioxide, to the intestines to obtain nutrients, to the kidneys and to the liver to remove the toxins and waste from the blood. And then they take it all back to the heart to repeat the entire process again. And that's how we live. So arteries. Arteries carry blood away from the heart. So they're carrying blood from the left ventricle to the rest of the body. They're away from the heart. And they have thick and strong walls. And why is this? Can anyone tell me why arteries have thick and strong walls and why they are thicker than the veins? I want someone to answer, please. Someone answer, please. Why do the arteries have thicker walls than the veins? For pumping blood. But you have blood both in the veins and the arteries. So why specifically do the arteries have thicker walls? Because the veins also have blood. To withstand the pressure. Okay, why is there more pressure in the arteries than the veins? You're very close, and you're half right, to withstand the pressure, right? But why? Why do we have this pressure? Okay, okay. So basically, right, when the heart pumps, the left ventricle is really powerful. In fact, it's more powerful than the right ventricle even. The left ventricle, when it pumps, it expulses, it moves the blood out of the heart in such a forceful manner that if the arteries were not thick, they would explode. That's why the arteries have thick and strong walls to withstand the pressure of the ventricles, like to withstand the pressure of the blood from the ventricles. Okay. And that's why their walls are thicker than veins. Veins don't have to deal with this because by the time you get to veins all the way later, all that pressure is lost already. Okay. Because the veins are all the way after the arteries, right? Because you go from artery to arteriole to capillary and then to veins. So by that time, the pressure is already done. So there's three types of arteries. There's elastic arteries, muscular arteries, and arterioles. So the elastic arteries wait, I'll explain this further after at the end. Let's move on to the next slide for now. Let's talk about atherosclerosis. Okay, it's so atherosclerosis. If there's too much cholesterol in the blood, the cholesterol and other substances form deposits, which is why, people always say you shouldn't eat food that increases your cholesterol or stuff like this. It's not only cholesterol, there's a bunch of other things. There's LDLs and oxidized. There's all stuff you learn in this year, actually, in biochemistry. But for now, just know that the cholesterol and other things form plaques. And these plaques collect on the walls of the arteries. As you can see in the picture that I have formed, when the plaques get larger and larger, they cause the artery to become narrower and narrower and narrower. And eventually, the plaque is going to completely block the artery. And when the artery is completely blocked, you have no blood flowing to that part of the body because the artery is blocked. Where's the blood going to go? It's just going to pool, right? So what happens? So based on the site of the atherosclerosis, there's different conditions. The first one is angina pectoris. So if you have atherosclerosis in your coronary arteries, these are the arteries that supply the heart. What are you going to have? The disorder is called angina pectoris. Basically, what you're going to have is a very sharp pain that is increased when you do a physical activity, and basically it happens when you have high demand. So when you're running, when you're jogging, when you're playing any sport, hiking, swimming, any of this, when your heart needs more blood to function, it's going to you're going to have angina pectoris, and it's caused by atherosclerosis in the coronary arteries. A stroke is caused by atherosclerosis in the arteries of the brain. So your brain, just like every other organ, needs blood. But if you have atherosclerosis in the brain, you have decreased blood. And eventually, when this atherosclerosis the plaque is large enough to completely block the artery, that part of your brain is going to die. And that's called a stroke. If the stroke is bad enough, you can die. You will die. If the stroke is not bad, then you may lose some parts of, your normal function. Like people that have strokes, they may become paralyzed from the waist down, depending on what part of the brain is affected. They may not be able to speak. They may be completely like locked out, only alive, but they can't move themselves, So this happens because of atherosclerosis in the brain. And then you have something called peripheral arterial disease, or PAD. This is caused by atherosclerosis in the arteries of the arms and the legs. So when you have atherosclerosis in these peripheral places, what happens basically is that you're gonna have numbing, you're gonna have like a jittery sensation. If you ever have an increased demand, such as if you're jogging or something, you're gonna feel pain in this part because the blood flow is not enough for that part of the body to function normally. It may function normally when you're at rest, but when the demand increases, it can't compensate because there's not enough blood going because of the plaque. So this is called peripheral arterial disease. So for example, it was mentioned in your slides, if you suppose you have atherosclerosis in the arteries that supply your legs, okay? You at rest you're fine, but when you walk, you feel an intense pain in your calves. This is called claudication. Claudication is pain when you're moving. Okay, the reason this happens is because of peripheral arterial disease. You don't have enough blood going to that part of the body. That's why it happens. Okay, now we get to the fun part too. This is why you joined the medicine. You wanted to learn about the body, and now you get to. So I'm gonna get my marker out. You have some arteries that are very important for you to know. So basically, when the aorta comes out, you have the ascending aorta, right? It comes out of the left ventricle. You have an aortic arch, and then you have descending aorta. Now you have a brachiocephalic trunk, and the brachiocephalic trunk has coming out from it a common carotid artery. This common carotid artery goes upwards. You can see the diagram. Wait, let me just give me a second. In this diagram over here, the one on the right, you can see the common carotid artery here. And where's the other one? Yeah, over here. You can see the left common carotid. It doesn't show the right one. But yeah, you have a common carotid artery. And this common carotid artery then divides into a external carotid artery and an internal carotid artery. These arteries supply the brain, right? So if anyone has any stoppage of these arteries when you choke someone, these arteries get compressed. There's no blood flow to the brain. If this happens for long enough, like 3 or 4 minutes, you're gonna die. Okay. So these are the common carotid arteries. They come out from the aorta. They have a brachiocephalic trunk there's a brachiocephalic trunk on only one side, but there's a common carotid that comes out from it on both sides, and then this common carotid, there's two of them. It's a right and a left, and both of them divide into external and internal. So external carotid, internal carotid on the right, and then external carotid, internal carotid on the left. Then you have a subclavian artery. Subclavian artery is over here. Okay, it's this artery that runs here. Okay, when the subclavian artery goes down, it becomes the brachial artery. The brachial artery up until your cubital fossa. Remember, this is called the cubital fossa. Up until this point, you have the brachial artery, and this is actually where you check your blood pressure. Is the brachial artery. After the brachial artery passes the cubital fossa, it divides into two arteries: the radial artery and the ulnar artery. The radial artery goes down the side of the arm with the thumb. So this is the thumb. So it goes this way, and then the ulnar artery goes towards your pinky finger. Okay, and you can see over here, you have the subclavian, right? And then from the subclavian, it goes down, becomes the brachial over here, somewhere over here. And then from the brachial, you have here's the brachial. You see the brachial here. Just follow where it's going. And then you have the radial and the ulnar. the radial towards the thumb, the ulnar towards the pinky, right? Then in the heart, you have the coronary arteries. The coronary arteries of the heart actually, the heart, the first organ that the heart supplies is itself, because the coronary arteries, they're like on the surface of the heart. The inner walls of the heart, so there's three walls I told you. There's the myometrium, sorry, wait. There's the endocardium, the myocardium, and the epicardium. Sorry, there's the epicardium, the myocardium, and the endocardium. The endocardium layer, which is the where the what is it called? The ventricles, where the fossa is, the heart supplies the blood directly. There's no arteries even. But the outer part of the heart, the epicardium, is supplied by the coronary arteries. Okay. In the abdomen, when the aorta goes down, it forms a thoracic aorta, all right? Which is, there's really not that many branches. And then it goes down and becomes the abdominal aorta. The abdominal aorta has a lot of branches that are really important. The first one is the celiac artery, which is for your stomach. You have the renal arteries. These are for your kidneys. You have the superior inferior mesenteric arteries, and these are for your small and large intestines. So I'll show you over here. So the superior, you see the renal artery here. There's the renal artery. You have the superior mesenteric artery over here. You have the inferior mesenteric artery over here. So these arteries are supplying the intestines, and the renal artery is supplying the kidneys. There's two, one on each side. Similar, superior inferior mesenteric, there's also two, right and left. Renal, there's two, right and left. And then you have the pelvis. So once you're done with the abdominal aorta, okay, it divides into two. Okay, you have there's two common iliacs. When the abdominal aorta is done dividing, there's two common iliacs. And the common iliacs divide into two further, an external iliac and an internal iliac. Okay? When the common iliacs are done dividing, they become the internal iliac and the external iliac. The external iliac then continues as the femoral artery. So let me show you here. You have the common iliac here, which is as soon as the abdominal aorta finishes, it's the common iliacs, the two of them. Okay. Then the common iliacs themselves divide into an external iliac, which is going on the outside, which is with lateral thigh, and then internal iliac, which is medial thigh. Okay. Then the external iliac continues as the femoral artery. The femoral artery then divides, it has the profunda femoris, or the deep femoral artery. And you're going to have a great time in MSK learning all of this, don't worry. This is just an introduction. So then you have the popliteal artery, right? The popliteal artery is in the popliteal fossa. Remember I told you about the popliteal fossa way like an hour or two ago. It's right behind the knee, the fossa behind your knee. And then you have a tibial artery and fibular artery as well. So the tibial arteries, there's posterior tibial artery and anterior tibial artery. There's a fibular artery as well. The popliteal artery, all of these come from the femoral artery, are continuations of the femoral artery. And then you have a peroneal artery. Honestly, it's not that important. I myself don't know what the peroneal artery is. The dorsalis pedis is an important thing to know, though. It's the pulse, which is the most distal in the body. The most distal pulse in the body is the dorsalis pedis pulse, and you can feel it somewhere between. You go in the webbing between your large toe, between your first and second toes, and then you go up slightly, and you might feel it. The dorsalis pedis is the most distal pulse in the body, so it's really important to know it. But yeah, that's it for the blood supply. Does anyone want to ask any questions? Again, you don't need to know it in a lot of detail because you're going to do this later, but you need to know the main ones. So basically, you have the aorta, the abdominal aorta, the iliacs, then you have the external internal iliacs, you have the femoral, you have the tibial and fibular. Both of them come from the femoral. You have the carotids, you have the subclavian, the brachial, the radial, the ulnar. These are clear, right? Can someone give me a yes or a no? One second. I want more than one person to answer, though. Yeah, okay, good. Okay, great. Let's move on then. We're almost done, inshallah. Now, capillaries, as I told you earlier, I already explained this earlier, but when you have an artery, you have a large artery, it becomes a smaller artery, then an even smaller artery, and then it becomes an arteriole, okay? When the arterioles when they divide, they become capillaries. The capillaries are so thin, like their basement membrane and endothelium are so thin that their gases and nutrients and waste products can diffuse between the capillaries and the tissues. So the capillaries give the tissues oxygen, and the tissues give them carbon dioxide and waste so that they can dispose of it. But there's no capillaries in the cornea, in the epidermis, and in hyaline cartilage. And this is really important because, if you have an injury to your cornea, it can't heal. It can't heal because there's no blood, there's no capillaries going there. So they can't send the good stuff to the cornea. The cornea, if it's damaged, it's forever, it's done forever. Similarly, for cartilage, they have no blood supply. For example, when a person tears their meniscus or tears their ACL or something like this, these are cartilaginous structures, and once they're damaged, like they can't be fixed because there's no blood supply. So how are you going to fix it? That's why when you injure your meniscus, most of the times it never goes back to how it was. You can try treatment, but it's never going to go back to how it was. So yeah, that's it for capillaries. Now we're going to talk about veins. So veins carry blood towards the heart. The others were carrying the arteries were carrying it away from the heart. The veins, they carry it towards the heart. So there's pulmonary veins which return these are the exception. So they don't carry deoxygenated blood. All the other veins do, but pulmonary veins carry oxygenated blood from the heart to the heart from the lungs. So the pulmonary veins leaves the lungs, enters the left atrium. And then you have systemic veins. These are the ones that actually carry deoxygenated blood all the way. They merge to become bigger veins, and then they merge to form the superior vena cava and the inferior vena cava, and then those enter the right atrium. So veins have valves to prevent the backflow of blood, and arteries don't have valves. So why do arteries not have valves? Can someone answer this? Someone answer why arteries don't have valves. I need someone to answer this. Yeah, right. Exactly. The exact answer is that the pressure is what matters. In arteries, you have a lot of pressure, which means the blood's not going to flow backwards. Why would it flow backwards when there's pressure pushing it forwards? The veins, on the other hand, they have no pressure. They need to go back. The blood from the veins, especially the blood that's coming from the lower limb, it needs to fight against gravity to even go up to the heart. And that's why it has a tendency to, flow backwards and pool. And this is prevented by having valves. So you have valves so that the blood can't pool and backflow. The veins obviously have much thinner walls than arteries, and the reason for this is because they don't have pressure. The pressure in the veins is much, much, much lower than those in the arteries, so they don't need large walls. Now we're going to talk about the major veins that you need to know. So the first one is the superior vena cava. This drains all of the blood from the upper limbs and the upper part of the body and sends it to the right atrium. So you have the brachiocephalic vein. The brachiocephalic vein is this one over here. Brachiocephalic here. Brachiocephalic. And the brachiocephalic is made up of two veins, a jugular vein and a subclavian vein. So the jugular veins are coming from the neck. Subclavian veins are coming from the arm. They drain the arm. When these two meet, you have a brachiocephalic vein. You have two brachiocephalic veins, one on the right and one on the left. So the brachiocephalic veins and the azygos vein, both of these form the superior vena cava, and the superior vena cava is the one that drains into the right atrium. Remember, there's only one superior vena cava, not two, and it's present to the right side of the heart, okay? So the left brachiocephalic vein has to cross the midline to get to the brachiocephalic vein. The left brachiocephalic vein has to cross the midline to join the right one so that they can become the superior vena cava. And the reason why this is important, well, I'm not going to tell you now, but it is important and you'll figure out later. This is the azygos vein over here. The inferior vena cava, on the other hand, this is supposed to be I here. I don't know why it says C. So this is IVC. Inferior vena cava is the one that drains blood from the lower part of the body and brings it back to the heart. So there's external, internal, and common iliac veins. So let's look for them on the diagram. Here's the external iliac. Here's the internal iliac. So both of the external iliac comes from down, from all the way from your legs. The internal iliac comes from your thighs. They both meet, they form the common iliac, right? The common iliacs, there's two of them, right and left. The common iliacs merge together, and this is when you have the formation of the inferior vena cava. And now, in addition to this, you have the hepatic veins. The hepatic veins are from the liver. They also join the inferior vena cava, and then the renal veins, which is very important. The renal veins also join the inferior vena cava. So all these three veins form, they join the inferior vena cava, and they go up to the right atrium. So yeah, I have the diagram for you guys as well. Go over them. It's important that you know all of these. Now we're talking about lymph, and then we're done for the day. I know it's been really long. I apologize for how long it took. Just want to make sure that you guys understand everything. Okay. So yeah, now we have the organ system, the lymphatic system. So the lymphatic system transports and filters lymph. And we'll talk about what lymph is. The lymphatic system may also participate in immune response, and it's one of the pathways for spread of metastatic cancer. So metastatic cancer is a cancer that spreads from its original site. And one of the ways in which it can spread is the lymphatic system, especially carcinomas, which are cancers of the epithelium, are much more likely to spread via lymphatics. Whereas sarcomas, which are cancers of the muscle, or other types of cancers that are much more likely to spread hematogenously. Hematogenously means through the blood. So, but carcinomas specifically spread lymphatically. They spread through the lymph system. And it's extremely important for fat and large protein molecule absorption. So something that you might not know is that the digestive system can't directly absorb fats. They actually need the lymphatic system to transport the fats to the circulation. They can't do it themselves. And here, the diagram that we have on the top is you have these lymph capillaries, right? These lymph capillaries are, wait, let me have my thing. These lymph capillaries over here, they have lymphatic fluid within them. And this lymphatic fluid, what these lymph capillaries do is they take the extra fluid, the extra intercellular fluid. So, you know, when you have cells, the cells, in between cells, you have fluid. This fluid is called the extracellular fluid or the interstitial fluid. So the excess interstitial fluid is taken up by the lymph capillaries, and then it's transported to the lymphatic vessels. The lymphatic vessels, then they take this extra fluid and take it to lymph nodes. Okay? Lymph nodes have a bunch of, immune cells that filter through this extra fluid to make sure that there's no bacteria, there's no cancer, or stuff like this. Then it goes from the lymph nodes all the way up to either the right lymphatic duct or the thoracic duct. All the lymph in the body ends up at these two ducts. And the right lymphatic duct is over here. It's literally right above your collarbone or your clavicle. Feel it. You won't feel it, but that's exactly where it is. And then you have the thoracic duct or the left lymphatic duct, which is above your left clavicle. So all of the lymph in your body eventually goes through these ducts, and then these ducts put the lymph back into the venous system, and then the whole cycle repeats. When extra interstitial fluid is found, is going to go into the lymphatic capillaries, into the vessels, into the nodes, and then through the ducts back into the venous system to return to circulation. Is that clear to everyone? Can I please get a yes? It's important that you understand this. Great. I'm glad you understand it. Good, 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 good. Right, let's move on to the next slide then. We're going to come back to this slide for the diagrams, but yeah. So what is lymph? So lymph is a clear watery fluid that's collected from intercellular spaces. So when you have excess interstitial fluid or extracellular fluid, that goes into the lymphatic capillaries, and that becomes lymph. Lymph has no cells until lymphocytes are added to its passage when it goes to the lymph nodes. So when you have lymph in the capillaries or in the what do you call them, in the vessels, then there's no cells. But when they go to the lymph nodes have lymphocytes, which are immune cells. So it's very similar to blood. So it has water, it has fats, it has what else does it have? Water, fats, it has the lymphocytes. No, it's very similar to blood other than the red blood cells. The red blood cells are what makes blood, right? And there should be no red blood cells in the lymph. Well, there may be a little, but that's too high for you right now. But like that, Mostly there shouldn't be anything. So the lymph contains fat droplets, and these are chyle or chyle. I don't know how you pronounce it. Whatever you prefer. I call it chyle personally. So they contain chyle, and these are this is how the fat is absorbed in our body. So in the intestine, instead of fat being absorbed directly, it's covered, okay, and then it's sent into the lymphatic system, and it's called chyle. And then eventually, once the lymph is drained from the thoracic ducts, that's when this fat enters circulation. It doesn't enter it directly like proteins and carbohydrates, which enter circulation directly from the intestinal system. Okay, it goes to the lymphatic system first. And lymphatic vessels. So this is really important, guys. All lymph in the upper limb is filtered via the axillary lymph nodes. And there's 5 groups of axillary lymph nodes. They're present in the axilla in your armpit, and all the lymph in your upper limb is filtered from this. All the lymph in your lower limb is filtered via the inguinal lymph nodes. Remember the inguinal, I told you about the inguinal region earlier in the lecture. It's like near your thigh. So there's lymph nodes there, and all of the lymph nodes are in the lower limb are drained through these. So upon filtration of the lymph in the lymph nodes, and then it eventually goes up to the thoracic duct, which is this one on your left, or the right lymphatic duct on your right, it returns into the venous system. But there are certain organs that have no lymphatic drainage. An example of this is the brain. A brain, the spinal cord, the eyeballs, the bone marrow, the hyaline cartilage, the nails, and the hair have no lymph vessels. So there's no lymph drainage from these vessels. And lymphatic vessels also have valves, just like veins. And the reason for this is obvious because the pressure is not high, so they can pull, can go back, and you don't want that to happen. And let's go back to this picture. I want to show you this thing. These are the axillary nodes over here. They're under your armpit, and everything in the upper body is drained via this. These over here are the inguinal lymph nodes. They go this way, look, this, like this, like this. These drain everything in your lower body. And then you have the thoracic duct and the right lymphatic duct. And you can see them over here. This is zoomed in for you on this picture. Here's the thoracic duct, which is on the left, and then the right lymphatic duct on the right. They're both draining into the venous system. Okay. Yeah, that's it. That let's go on to the next thing now. Metastatic cancer. So I already told you, metastatic cancer is cancer that spreads from where it originally started. That's it. Lymph vessels are the main route for the spread of carcinoma, and blood vessels are the main route for the spread of a sarcoma. Okay, carcinoma is epithelial cancer. Sarcoma is cancer of the muscles and the connective tissue. In metastasis, the cancer cells break away from where they are originally. Let's say you have, let's say a person has a cancer of the uh, ovaries, right? Now, when cancer cells break away and they enter the interstitium, the lymph picks it up. Okay, the lymph picks it up, it goes to the lymph nodes. The lymph nodes are the first part of the body to be infected. And this is an early sign of metastasis. Now, if the lymph nodes don't catch it and don't remove this cancerous cell, it will move to other parts of the body. Let's say it moves to your kidney, okay, or your liver. And now this cancer cell is going to grow there, and this is going to be a secondary tumor. This is not the main tumor. The main tumor is in the ovary. So this whole process is called metastasis. So lymphatic capillaries and lymph nodes. So first of all, wait, let me just erase everything on the screen first because it's kind of distracting. We're almost done, guys. This is like the second last slide, I think. So just hang on, we're almost done. So yeah, lymphatic capillaries begin blindly, and what that means is they don't have, like, you know how arteries begin and then they become bigger and then bigger, or sorry, arteries begin, they become smaller, 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 become capillaries, veins, bigger, bigger, bigger. No, lymphatic capillaries begin blindly, so they literally just start out of nowhere. Out of nowhere they start in most tissues. They collect the tissue fluid, which is the interstitial fluid, and then they form bigger vessels called lymphatic vessels, and then these lymphatic vessels go to regional lymph nodes. And then let's talk about lymph nodes. Lymph nodes are lymphatic tissue that are organized and that the lymphatic vessels drain into. These lymph nodes contain lymphocytes, which are immune cells that look for bacteria or look for anything toxic and remove it from the blood. And they filter the lymph. The lymphocytes also trap bacteria that come from an infected region. So, for example, some of you may have noticed this, but if when you're sick, your lymph nodes actually become tender, and a doctor examines the lymph nodes, and if the lymph nodes are tender, that's a sign of infection. And the reason they're tender is because the bacteria is trapped in the lymph nodes, which causes them to become large and tender. Okay, so for example, if you have an infection, like let's say you have the flu or something like that, so the lymph nodes in your neck are going to be enlarged and tender because these are the closest lymph nodes to the nose and the respiratory system, right? So because of the uh, bacteria being trapped there, they become large, okay? And the lymph nodes have reticuloendothelial cells and phagocytic cells such as macrophages. I'm sure you guys have learned this already. The macrophages are basically, they just engulf the bacteria. Reticuloendothelial cells are like support cells that form the structure of the lymph nodes. And then you also have a specific type of lymph vessel called the lacteal. And lacteals are in the villi of small intestines. So when you absorb fat in the small intestine, I told you you have the formation of a chyle, which is a fat molecule. This fat molecule is transferred into a lacteal. And these lacteals go all the way up to the right and left thoracic ducts, or should I say the right thoracic duct and the, what's it called? The right thoracic duct and the other duct, and then they enter circulation. Not directly, like carbohydrates and fats. Now we're on to the last two organ systems, the respiratory system and the urinary system. The respiratory system, the only function of the respiratory system is gaseous exchange. So you breathe in oxygen, you breathe out carbon dioxide. That's it. The respiratory system has two parts. It has a conductive portion and a respiratory portion. The conductive portion includes the nose, nasal cavity, the paranasal sinuses, the pharynx, the larynx, the trachea, and the bronchi. Okay, so all of these are the conductive portion. And what does this mean? This means that these conduct the air down to the respiratory portion. There is no air exchange going on in the conductive portion. The only job of the conductive portion is to get the air to the respiratory portion. The respiratory portion are the lungs. And if you want to be more specific, they're the alveoli. The alveoli are the building blocks of the lungs. It's basically where all the exchange happens. And that's why it's called the respiratory portion. So the conducting portion, there's no exchange, just transport. Respiratory portion, there's exchange. In the alveoli, very specific. The alveoli are these thin kind of endings of the lungs after everything. The respiratory, this is where all the respiratory exchange happens because they're so thin, they're just one cell thick, okay? Then you have the urinary system. The urinary system consists of two kidneys, two ureters, a urinary bladder, and a urethra. So the two kidneys make the urine is drained into the urinary bladder via two ureters, one for each kidney. And then the urinary bladder stores the urine until it's a proper time to urinate, and then through the urethra, the blood leaves, and then it exits the body. So what's the job of the urinary system? Is easy. It's removal of waste products and biologically active molecules. So, for example, catecholamines leave through urine. There's a lot of drugs that are excreted through urine. And at the same time, urea, nitrogen, and other harmful substances are also removed via urine. And yeah. Oh, we have two more, but then this is generally the last thing. Yeah, promise. Digestive systems includes the mouth, the pharynx, the alimentary canal, which is basically like it's right before the esophagus. And then you have the esophagus, and then you have the stomach and the small intestine and the large intestine. So all of these are part of the digestive system. You also have salivary glands, liver, and pancreas, and these all produce enzymes to break down the food. Now, the breakdown of food is not only via enzymes, it's also mechanical. So, for example, when you're chewing, you're breaking down the food into smaller pieces, or in the stomach, this food gets mixed up and also broken down into even smaller pieces. And then peristalsis breaks it down further. So it's not only chemical, it's also mechanical. So mechanical plus chemical is what's responsible for the breakdown of food. And the function is absorption of nutrients and waste products. It absorbs the nutrients in the stomach and the intestines, and then expels the waste products through the rectum and the anus, Rectum and anus, by the way, are parts of the large intestine. The small intestine also has three parts: duodenum, jejunum, and ileum. You don't need to know this for now, but I'm sure most of you already know it. The stomach also has three parts. It has like the fundus, the body of the stomach, and the pyloric part of the stomach. Anyway, you don't need to know this at all. I'm just telling you. And then you have the reproductive system, which is the testes or the ovaries, depending on your gender. Males have testes, female have ovaries. So what do? The testes produce sex cells that are male. The male sex cells are sperm. Okay? So testes produce spermatocytes via a thing called spermatogenesis, which is how you form the sperm. Again, you learn this. I think it's in this block maybe. And then if you're female, you have ovaries. And what do they produce? They produce sex cells that are female called oocytes. And you know, the oocytes, every menstrual cycle, you have one oocyte that's released, right? And then if the oocyte is not fertilized by a sperm, then you have a period. And then, in addition to the production of sex cells, you have hormones produced by the reproductive organs. So in males, they're called androgenic hormones, okay? So testosterone, and there's a bunch of other androgenic hormones such as DHT, dihydrotestosterone. You don't need to know this. I'm just yapping, honestly. But testosterone is the main one. Testosterone, okay? In males. In females, estrogen and progesterone, and there's a couple of other versions as well, such as estradiol, which you don't need to know. But yeah, that's produced in females, and males, testosterone by the reproductive hormone. So that's it. I'm sorry I took so long. It took me almost 3 hours, but I promise you, this crash course has everything you need. These 3 lectures, you do this crash course, that's it. Everything 100% in the exam, I promise you. I wish you good luck. I don't think I'm going to do another one for this session, for this cycle, I mean. So this is the only one that I'll have with you for FND and which includes also heme, I think. But yeah, so good luck with the exam. I really hope you do well, and I hope all of you get a great grade, inshallah. That would be amazing. And if all of you watching, even if you're watching the recording on YouTube after, please scan this QR code, give me a good feedback. So you know I can keep making these sessions if you enjoyed, that is. Obviously, I'm not forcing you. And then there's also a quiz here that will test whatever you've learned in these 3 lectures. So I'll just go over the chat one time. Oh, guys, thank you so much for being here. I know I took so long, but I promise you it's going to be worth it. This is everything you need for the exam. So yeah, thank you, guys. Please do the feedback, the QR code, scan it. It's going to take like a few minutes at most. And yeah, that's it. I'm done. Thank you very much. Thank you so much.